Piyush, you can start.
Yes, ma'am. The live process is under.
If you can call Dr. Ashok Kumar, please, Nutan. I had given him a message also, but just if you can.
I'll have to mute myself for just a minute.
We are live now. I'm sharing the screen. Good evening, respected faculties and all the delegates, those who have connected with us for our Poor Collect platform. This is Piyush Shukla from Corona Remedies. Welcomes you all on Amogs Emergency Obstetrics Committee with UPCOG, Kanpur, Bulandshahr, Aligarh, Azamgarh, Jhansi, Shahjahanpur, and Khora Makanpur societies on the episode 16th. With all due respect, I'd like to introduce you all with our esteemed faculty member and convener, Dr. Bharti Maheshwari ma'am. She is professor and head department of Obs and Gynae and IVF, Muzaffarnagar Medical College. She is DIP in IVF and reproductive medicine Germany. She has a lot of achievements under her name. A very warm welcome, ma'am. Another one, I like to introduce you all with our coordinator, Dr. Nutan Upadhyay, ma'am. The lady needs no introduction, but yet I'd like to mention few of her major achievements. She have been felicitated with Nari Shakti Champion Award, awarded under Pradhan Mantri Surakshit Matritva Abhiyan, IMA UP President's Appreciation Award, and many awards under her name. A very warm welcome, ma'am. And for further proceedings, I'd like to hand over the session to you.
A very good evening and a very
Please
warm.
stop sharing, Piyush.
Yes. Very good evening and a very warm welcome to all the respected faculty members and the guest of honors and the chief guest.
I think, Nutan, sorry to interrupt you. We will have to go ahead. So I will just do a quick welcome without anybody's introduction.
Yes.
A very good evening to all of you. Of course, my respect and regards to all the three patrons of UPCOG, Padma Shri Madam Usha Sharma, Madam Meera Agnihotri ji, and Madam Chandravati ji. My respects and regards to the chief guest of today's program, Professor Madam Kamal Bakshi, Ashok Kumar as guest of honor, and also Dr. Kiran Sanna, Madam as guest of honor. I would just say that on behalf of the entire team of Amogs, my dear friend Dr. Kiran Kurtakoti as president, my mentor Dr. Rajendra Singh Pardesi as immediate past president of Amogs, the secretary Dr. Bipin Pandit, treasurer Dr. Madhuri Mender, and of course national coordinator our dear friend Dr. Parag Biniwale. All of us welcome all of you, and again I thank the entire team of UPCOG, especially my dear friend Dr. Bharti Maheshwari as the convener of this series, and Madam Kirti Dubey as the president of UPCOG, also Madam Nurada Khanna as the immediate past president of UPCOG, and Dr. Bharti, I have already said she is the secretary as well for UPCOG. I would just say that, you know, as this emergency obstetric committee, we are trying to take this ahead and going to all the Foxians. This is a humble attempt to, you know, minimize the maternal, not only maternal, but maternal and perinatal mortality and morbidity. And that is why we have selected the topics also today as the evidence-based technique for cesarean section by Dr. Bhaskar Pal, whom all of you know so well, evidence as well as experience, and Madam Seema Hakim, who will be speaking on the optimizing cesarean section rate, not reducing, but optimizing cesarean section rate. And myself, Dr. Sneha Buyar, will be moderating the panel on HDP. All of you know that, you know, we have been talking about the so many predictive factors and screening tests for HDP, and in spite of all this, the incidence of PIH or HDP gestosis per se, and the complications and mortality associated is still not reduced to a significant extent. And that is why we are here to discuss this. I thank all the faculties, panelists, chairperson, and I also take this opportunity to thank all the president and secretaries of all the societies. I would just name them because they have been so active and enthusiastic. Dr. Meenakshi Sood and Zehra Mohsin from Aligarh, Dr. Seema Pandey and Archana Masi from Azamgarh, Dr. Pramila Mittal and Indu Singh from Bulandshahr, Dr. Alka Sethi and Dr. Vidya Chaudhary from Jhansi, and of course Dr. Shobna Goyal Mittal and Ritu Mittal, and also Dr. Kalpana Dikshit and Dr. Reshma Nigam from Kanpur, and Dr. Tandon, and of course Deepika. So I thank all these society president, secretary, and my once again my special thanks and respect and regards to Madam Meera Agnihotri ji and Kirti Dupe Madam, to take this series ahead. So thank you so much, and I would just like to welcome Madam Meera Agnihotri ji for her few words of blessings and guidance. So over to you, Madam Meera ji. Madam, please unmute yourself. Hello. I think
डॉक्टर स्नेहा आपको दिख रहा है मीरा मैडम? आई एम नॉट एबल टू सी हर.
नहीं वो है.
Madam knows about it. And hello, madam. I think the audio, I don't know whether she can hear. I will call by the time. Yes.
मीरा मैम प्लीज अनम्यूट कर लीजिए. आई कैन सी मीरा मैम बट शी हैज नॉट अनम्यूटेड.
Yes,
yes now.
Madam, we are eagerly waiting for your blessings and your guidance. Over to you, madam.
Sneha, a lot many people have come to my residence from out station. I'll be here. I really love you. I really admire you. I really enjoy the company of the person sitting over there and the dais with which I am sharing. The speaker I love, but for the reasons unknown, I may not be able to continue, darling. मुझे बहुत मजा आ रहा है और मैं चाह रही हूँ कि तुम्हारी जितनी भी एकेडमिक मीटिंग्स हैं, they must go wonderful. And I know that you are doing great justice with the academics. You are very much interested in academics. And the speaker you have got, he's really an academic Dian, and he may talk anything on any subject. I don't find that Usha ji or Chandra ji is here, but if she was there, you see, it is always a pleasure to share the dais with them. So Sneha, you please continue with the program. I will be able to join, say, after half an hour or 1 hour. I will definitely join. I really enjoy this academic session, but many people are sitting with us in our residence. I'm there on this meeting. Hello.
Yes, madam.
Can you hear me?
Yes, madam.
मैडम स्नेहा, मैं 4 बजे से मीटिंग्स अटेंड कर रही हूँ, 4 से 5, 5 से 6. नाउ दिस इज आवर थर्ड मीटिंग and I really enjoy it. And everybody seen Bharti, Nutan, Sneha, Kanchan is there, Kalpana is there. They will extend a hearty invitation to all of you to be with us in the conference on 21st and 22nd of September. And we have got lovely sessions for the professors and the all persons who can accommodate with the national certificate. So from top to bottom, meaning thereby the seniors can also present their important cases which we will really enjoy. So Kalpana and Kanchan, इन लोगों को बता दो कि बड़े बड़े प्रोफेसर्स जो हैं उनके कोई बहुत इंटरेस्टिंग केसेस है. वी आर ऑल interested in watching them, seeing them. they will be given proper time, and then we have got national prizes for them, first, second, third, and 7 consolation prizes, and the judges will be our past president for 3 years. So
Thank you,
please,
Meera madam. Namaste. Thank you. Bharti is here. And thank
भारती,
you. Yeah.
तुम्हारा इम्पोर्टेंट काम तुम्हें मालूम है एज यूजुअल।
हाँ, मुझे मालूम है, हम बहुत सारे लोग जरूर होंगे 21, 22 को भी,
और
ऑल विल बी देयर।
हमारी प्यारी भारती भी होगी, और हम चाहते हैं कि कोई बहुत इंटरेस्टिंग सी चीज तुम प्रेजेंट करो, जो हम लोगों ने पहले कभी ना देखी हो, सुनी हो, इंटरेस्टिंग केसेस, इंटरेस्टिंग सब्जेक्ट। तो ये हम लोग का सीनियर्स का ये फॉर द फर्स्ट टाइम हम कर रहे हैं। एवरीबडी विल बी गिवन चांस टू प्रेजेंट देयर केसेस।
Definitely, madam. We all will be there. We all will be there. We have blocked that
Thank
date.
you so much.
Right,
Thank
right.
you, madam. Thank you so much for your blessings.
Yeah,
always.
I know that तब तक तुम बन चुकी होगी जो तुम्हें बनना है, तो सितंबर तक रिजल्ट आ गया होगा, आई बिलीव। ऐसा है कि नहीं है?
नहीं आएगा, आपका 1 हफ्ता पहले रहेगा। 28 नहीं, रिजल्ट आ गया होगा,
आ जाएगा,
रिजल्ट आ गया होगा,
आ जाएगा। हाँ,
रिजल्ट शायद आ गया होगा,
आ जाएगा, ऑनलाइन है, रिजल्ट आ जाएगा।
Yes.
अच्छा,
Thank you.
चंद्रा जी और उषा जी इज नॉट देयर, बट आई एक्सटेंड माय रिगार्ड्स टू देम बिकॉज आई ऑलवेज शेयर, एंड ये मेरी अपीयरेंस से तुम समझ सकती हो कि आई एम ए लेबर क्लास वर्किंग सिंस मॉर्निंग एंड माय वर्क इज नॉट ओवर। So I extend a hearty welcome invitation to everybody. वेबसाइट पे हमारा पड़ा हुआ है, फॉक्सी की वेबसाइट पे हमारा इनविटेशन पड़ा हुआ है। आप लोग सब बहुत 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 इनवाइटेड हैं।
थैंक यू मैडम।
आज की मीटिंग के लिए स्नेहा फ्रॉम होल ऑफ द कॉक्स फैमिली एंड फ्रॉम ऑल द फ्रेंड्स अराउंड यूपी के, इंक्लूडिंग भारती और ऑल ओवर द सिटी ओवर देयर, मेरा जॉइंट extension of good wishes for a wonderful success, for a wonderful program. Thank you very much, darling.
Thank you, madam.
Thank you.
मुझे बहुत अच्छा लग रहा है तुम लोग के साथ बैठने में, खास करके स्नेहा के साथ पंचायत करने में मुझे I really enjoy it. It's interesting when we discuss with each other.
Dr. Kamal Bakshi madam is
we will
also
join
there.
Thank you,
again.
madam.
Yeah.
And I mean, we are very eager to have Madam Kamal Bakshi's blessings as well. All of you know her as past president of Foxy. And
by name हम सबको नहीं बुला पाई स्नेहा,
yes,
मैं by name सबको नहीं बुला पाई हूँ, but you take this responsibility. Kanchan and Kalpana, they are there. Bharti is my representative. You just invite on our behalf. Bharti is a part of our family,
madam.
so she will do that.
Definitely.
Thank you so much. Thank you so much.
Yes.
Thank you.
Best of luck. Best of luck.
Thank you, ma'am. Namaskar, ma'am.
Okay.
So
You
we are
have to come,
eager to listen to
पूरी
Madam
बात सुननी कि
Kamal
नहीं?
Bakshi, and over to you, Madam, for your precious words.
Right. कमल बख्शी जी को मेरा प्रणाम करवा दो, मैं तो उसके बाद जाऊंगी।
प्रणाम प्रणाम।
कमल जी आपको बहुत 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 सादर प्रणाम मेरा, और यहाँ जितने लोग बैठे हुए हैं मैं उनको एक चीज बताना चाहती हूँ कि मेरी फर्स्ट नेशनल कॉन्फ्रेंस फॉक्सी की 1995 में, इट वाज गाइडेड, गवर्न and really being shoulder to shoulder with me, Kamal ji. She is a very senior but a very loving member of mine. उनको मैंने जाड़े में उन्होंने मुझे एक शॉल दी थी कि मैं दिवाली पर भागी चली आ रही थी फ्लाइट से। I have kept that shawl as a token of love for me. कमल जी, I always remember you. आपकी एक एक चीज मुझे याद है, आपके बच्चों का प्यार और डॉक्टर साहब का स्नेह जो मुझे मिलता था दिल्ली जाकर के। आई कन्वे माय रिगार्ड्स। थैंक यू वेरी मच।
मैडम सबको आशीर्वाद दे दो ना, ये लोग जीत जाएं।
जैसे अब कम से कम 6 महीना बचा ना,
Yes, yes.
मैडम का आशीर्वाद है। अब कमल बख्शी मैडम नमस्ते।
गया है हमें, no problem, and we are waiting eagerly for your words, Madam. Professor Kamal Bakshi, over to you, Madam.
Dear
Piyush, can you please mute rest everybody?
Bharti and everybody, and it's such a great pleasure to see the new.
होगा तो बताएंगी ना, ये पहले से कैसे कोई बताएगा? रिपोर्ट सही है।
Can I start?
Yes, ma'am. Please.
Madam, please.
Acha. Dear Sneha, dear Meera ji, Usha ji, and everybody, I would say Bharti and Nutan, I mean Kanchan here, each one that is present here, the senior people, the dons and the legends, and the young bubbling youth, and the people who are here, who are going to be the future, the vice presidents of the Foxy and the president of Foxy. So all my hearty and best wishes to them. And what I would say is that I congratulate you that you have chosen such a vital topic, as far as the maternal and perinatal mortality is concerned. And I will take you back as far and even the topics of the cesarean section that you have taken, the topic as far as the techniques are concerned with Bhaskarji, and every topic is so good. So I'll take you back as far as the late 80s, I was called by my medical superintendent, said, Dr. Bakshi, the operation rates have gone down, So I told him that I have started doing my morning round with the audit. And what we found in our audit, that the cesarean section rates were much higher during the night. And even the episiotomies were done early. The restless children who were there at night with the occipito-posterior abnormal position, the unwanted or the early episiotomies. And I said, sir, would you want your wife to have a cesarean to increase the operation rate? He said, no. So that was as far as the cesarean section is concerned. And then coming to as far as the technique again is very important. In 2000, what happened was that I saw a case of cesarean scar pregnancy. And what was there that when we were having coffee, most of the people would discuss, oh, I did it in 3 minutes, 5 minutes, cesarean section. And they used to quietly smile that, are we going to drive fast and create more accident? It is the safety of the mother, safety of the child. It is not the time that matters. It is the methodical and the steps, that is most important. And then this was followed by isthmocele. See, just as when whether it is men or the women, you see with the abdomen hanging. Why? Because of the muscles are not all right. So if the cesarean section is not well, the scar is not good, and lots of problems can occur. So you have chosen such beautiful topics, and I feel that the latest that you are going to discuss. So I wish you with a great academic session, That is the beauty, and you have chosen people from the small and the big cities, all corners of India, So thank you. I am very pleased for your kind invitation, and namaskar and pranam.
Thank you so much, madam, for your words of wisdom, whatever. From your experience, you have been guiding us for so many years, and we continue to have your blessings as well as guidance. So may I have Dr. Kiran Sinha now as the guest of honor for her precious words for us. Madam Kiran Sinha.
Thank you, Dr. Sneha. Though I'm not feeling very well, I have got cold and everything, but I could not resist myself. क्योंकि आपने इतने प्यार से इतनी इज्जत से हमको बुलाया, शायद वो मैं इतना डिजर्व भी नहीं करती हूँ डॉक्टर कमल बख्शी मैडम के सामने और मीरा मैडम के सामने, लेकिन ये आपका प्यार और स्नेह है। और जहां तक रही सीजेरियन सेक्शन की बात, इसको आप जितना सीख लीजिए, समझ लीजिए, उतना ही लगता है कम है। आज का जैसा मैडम कमल बख्शी ने कहा कि कुछ तो कमियां हम लोगों के उसमें हो गई है, क्योंकि एक तो सीजेरियन सेक्शंस के रेट बहुत बढ़ गए हैं और दूसरा स्कार एक टॉपिक बहुत ज्यादा आ रहा है। तो कुछ चीजों का ध्यान रख करके वी कैन नॉट टोटली, बिल्कुल तो नहीं रोक सकते हैं, बट टेकिंग स्मॉल एंड स्मॉल स्टेप्स एटलीस्ट वी कैन मिनिमाइज दिस इंसिडेंसेस ऑफ स्कार एक्टोपिक एंड एंडोमेट्रियोसिस, स्कार एंडोमेट्रियोसिस। कुछ चीजें हैं और जैसे कि बहुत छोटी छोटी टेक्निक है, और हमको जितना भी हम सीधे रोज, मेरे ख्याल से आई वॉज इन गवर्नमेंट जॉब, तो वी यूज टू डू 20-30 सीजर्स एंड पर डे। और उसके हम लोग से वी यूज टू ऑलवेज स्टिच इन 2 layers मैडम। कमल जी। अब लेकिन अब ऐसा हो गया कि हम लोग वो जाओ ओटी में, अब नाउ आई एम डूइंग प्राइवेट प्रैक्टिस आफ्टर रिटायरमेंट। कहेंगे नहीं मैडम एक पे सिलो, हमने कहा हम एक पे नहीं सिलेंगे भाई, हम 2 में सिलेंगे। अच्छा, तो कुल मिलाकर के हम लोगों को जो मैडम सिखाया था, जैसे कमल बख्शी जैसे मैडम ने, कि पहले आप कॉर्नर बांध दीजिए दोनों तरफ के, उसके बाद फिर आप लीजिए, तो आपका बहुत कुछ बच जाता है। कॉर्नर की ब्लीडिंग ये बहुत छोटी छोटी, और हमको तो याद है हमारे समय मैडम 3 लेयर में स्टिच होता था, 2 लेयर में यूट्राइन मसिल्स और 1 लेयर में उसका पेरिटोनियम। और हमारी जो वो होते थे सीनियर, ऐसे खड़े होके झांका करते थे कि दूसरा लेयर पहले लेयर पे कवर हुआ कि नहीं हुआ, जरा सा कुछ खुल गया, खूब डांट पड़ती थी मैडम। तो हम अपने वो समय भी याद करते हैं, उस समय सीजेरियन इतना नहीं था, लेकिन था तो है ही, और एक करने को मिल जाता तो बड़ा मजा आता था मैडम उस समय। लेकिन अब तो सीजर ज्यादा हो गया, कुछ कारण इसका पेशेंट भी है और कुछ हम लोग भी है कि बिकॉज पेशेंट दे डोंट हैव पेशेंस एंड डॉक्टर्स दे डोंट हैव पेशेंस। अगर हम जितनी जल्दी जल्दी मरीज देखेंगे ना, उतना ही सीजेरियन रेट बढ़ जाता है, क्योंकि हम लोग खुद भी रेस्टलेस होने लगते हैं। क्योंकि और जहां तक मैडम देखिए ऐसा है ना, जब प्राइवेट प्रैक्टिस होती है 1-to-1 होता है ना, सिंगल होता है, बिकॉज आई एम इन बोथ, तो आई कैन रियलाइज द डिफरेंस ऑफ द गवर्नमेंट डॉक्टर्स एंड द प्राइवेट डॉक्टर्स। प्राइवेट में आपका एकदम 1-to-1 होता है, पेशेंट से आपका बिल्कुल अलग तरह का वो हो जाता है अटैचमेंट। अब वो एक दर्द में चाहती है कि अब मैडम लोग तो खड़ी रहे, अब तो मतलब पेशेंट दर्द न ले, हम पे कर रहे हैं तो दर्द तो डॉक्टर सेना ही को लेना चाहिए। दैट इज नॉट पॉसिबल। लेकिन धीरे धीरे 9 महीने हम लोग समझाते रहते हैं, तो थोड़ा थोड़ा भाई देखो ये होगा ये होगा ये होगा, तो धीरे धीरे जब आप उनको करते रहिए तो शायद उनको थोड़ा सा ये हो जाता है कि हाँ इतना घंटा पेन लेना पड़ेगा, ये करना पड़ेगा, तो शायद कुछ इसमें कुछ सीजेरियन रेट में कमी आएगी। और जैसा कि हमने एक मैडम सीमा हकीम के साथ मैंने एक, इन्होंने बहुत अच्छा वो किया था वेबिनार, उसमें मैं पैनल में थी, किस तरीके से पेरिनियल एक्सरसाइज है और मसाज है, एवरीथिंग वाज टोल्ड इन दैट एंड आई वाज इन दैट पैनल। ये सब चीजें, क्योंकि ये सब चीजें आपको मैडम बतानी पड़ेंगी थ्रू आउट एएनसी। हमारे में तो अब फोटो भी लगा रखी कि हाउ टू डू द एक्सरसाइज, व्हाट टू डू, ये सब चीजें फ्रॉम द वेरी फर्स्ट डे जब वो पेशेंट आती है तब से आपको बताना पड़ेगा, तो सो दैट वी कैन रिड्यूस द इंसिडेंस ऑफ सीजरियन सेक्शन लिटिल आई थिंक। और इसी के साथ डॉक्टर स्नेहा, मेरा बहुत बहुत आपसे बड़ी हूँ, बहुत 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 मेरा आशीर्वाद आप दोनों के लिए है। वी वांट टू सी यू एज वाइस प्रेसिडेंट नॉर्थ जो वो वेस्ट जोन दिस टाइम, एंड डॉक्टर भास्कर फॉर यू ऑल्सो। दिल से तमन्ना है आप लोगों के लिए। बाकी देखिए अब इलेक्शन तो इलेक्शन है, कभी सोचा नहीं था कि ये होगा, जो हो गया यूपी में मोदी का, तो क्या करें। और बाकी यू पीपल, यू आर ऑलवेज अवर लीडर्स, इतना मैं कह सकती हूँ। आई डोंट नो एनीथिंग
Thank you,
अबाउट
madam.
इलेक्शन, बट डॉक्टर भास्कर पाल इज ऑलवेज माई लीडर। एंड कमल बख्शी मैडम का तो कहना क्या, डॉक्टर सीमा हकीम, शी नोज कि हाउ मच आई हैव गॉट लव एंड रिस्पेक्ट फॉर हर। डॉक्टर भारती का तो कुछ कह ही नहीं सकते हम, एक कॉल देते हैं ये तुरंत भागी चली आती है, इसीलिए मुझे मेरठ भी भाग के जाना पड़ा, है ना।
थैंक यू मैडम।
तो मुझे पता है कि यू पीपल आर ऑलवेज अवर लीडर, whether you get through that election or not, it is immaterial, at least for me, but all my best wishes for both of you. Thank you so much, Dr.
Thank you, madam.
Thank
Thank
you,
you
ma'am.
for your
Thank you.
थैंक
very
यू मैडम।
lovely
मैडम
words.
मैडम
And
घबराइए मत, मोदी है स्टिल वन, मोदी नहीं जीता है।
so I have already welcomed Dr. Rajendra Singh Pardesi and Dr. Parag Biniwale. So by the time Dr. Bhaskar starts preparing for his presentation, may I have a few words of guidance from Dr. Rajendra Singh Pardesi, who is the immediate past president of Amogs. Sir, over to you for your words.
Good evening. Namaskar, sir.
नमस्कार
नमस्ते सर।
नमस्कार
नमस्ते
नमस्कार,
नमस्ते सर।
नमस्ते नमस्ते मेरा अग्निहोत्री मैडम,
नमस्कार।
शर्मा
Namaskar.
चंद्रावती मैम नमस्ते, एंड कमल बख्शी also. So many years Kamal, we met Kamal Bakshi ma'am on this platform, so really I'm feeling honored. Respected Dr. Usha Sharma, Dr. Chandravati, Dr. Meera Agnihotri, Chief Guest Dr. Kamal Bakshi ma'am, Dr. Ashok Kumar, Dr. Kiran Sunna, Dr. Bhaskar Pal, our Amogs President, Dr. Kiran Kurtekoti, Upcog President, Dr. Kirti Dubey, Dr. Anuradha Khanna, Dr. Bharti Maheshwari, Dr. Priyanka Garg, Dr. Parag Biniwale, Dr. Kanchan Sharma, and friends. I'm feeling really proud and honored to be a part of this webinar of Amog, jointly with Upcog societies, and mainly in the presence of all these motherly figures Dr. Usha Sharma, Dr. Chandravati ma'am, Dr. Meera Agnihotri, and Dr. Kamal Bakshi ma'am. So really feeling honored. I wish to congratulate and say to thanks to Dr. Sneha. Due to her only, I could attend this webinar and blessing from these mother figures. So I wish to congratulate Dr. Sneha Buyar for organizing this webinar on important topics of CS techniques, rates, and SDP, as already the stalwarts explained in details. I wish every success to Dr. Sneha Buyar for her future endeavor in FOXI as Vice President FOXI in this forthcoming election. And also to Dr. Bhaskar Pal. Bhaskar Pal is a true leader. We need leaders like Dr. Bhaskar Pal. I wish every success to Dr. Bhaskar Pal also. Wishing every success to this webinar. I don't want to be in between you and scientific content. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you
Welcome,
for
sir.
your
Welcome.
presence and your precious words also. Parag, can we have few words from you, the ICOG chairperson-elect and of course the national coordinator of Amogs?
Yeah, thank you, Sneha, for the invite. Indeed, a pleasure to be sharing dais with Madam Kamal Bakshi, one of my most favorites. And I still cherish the photograph we took long ago during the AICOG at Lucknow. Thank you, ma'am, for joining today. And of course, all the doyens of UPCOG. Sneha, you've chosen excellent topics and excellent speakers. Very dear friend Bhaskar, who will speak about evidence-based C-section technique. And of course, Dr. Seema Hakim, who will be really telling us about how to reduce C-section risk. And I'm also looking forward to the interesting panel discussion which you're going to host. It's a pleasure to be sitting in UP while sitting at home. So thank you. Best wishes to you. And of course, Bhaskar, best wishes to you as well. We all are with both of you. We want both of you to be occupying that very important chair of FOXI. Thank you.
Thank you, Dr. Parag, and welcome in UPCOG. Thank you.
Thank you, Parag. And without much ado, I hand over to Dr. Nutan quickly to just invite the chair. And I think we better hand over to Dr. Bhaskar. Otherwise, we'll miss the important parts of his speech, I think. Over to you, Nutan.
Let's start our first academic session, which is evidence-based CS techniques, as we discussed.
Quickly.
For this, I'm inviting our chairpersons, Dr. Meenakshi Sood, Dr. Kirti Tandon, and Dr. Somna Goel Mittal. These are our three chairpersons for this. Can we have the CV of Dr. Bhaskar Pal? Dr. Meenakshi Sood, can you please introduce our respected speaker?
Find Meenakshi,
Sure,
madam.
ma'am. Sharing right.
I can't see Meenakshi, madam.
Is Dr. Kirti Tandon, ma'am,
Yes,
here?
yes. Dr. Kirti Tandon, madam, is here. But she's muted.
Yeah. Or Dr. Somna Goel, if you are here.
Can you just display the CV fast?
Dr. Somna Goel, madam, is also here.
Dr. Meenakshi Sood is our president from Aligarh. Can we have a next CV? Dr. Kirti Tandon, our dear president from Shahjahanpur, and Dr. Somna Goel Mittal, the president from Khora.
Good evening, everyone. Yeah, I'm here.
Welcome.
Dr. Meenakshi Sood won't be able to join. Ma'am called me to tell that there's some family emergency. Thank you, everyone, for this opportunity.
Yes, please. Ma'am, please introduce our respected speaker, please.
Dr. Bhaskar Pal, sir, good evening. And it is my pleasure to introduce him. Everybody knows he's a very senior consultant gynecologist from Apollo Hospital, practicing in Apollo Multispeciality Hospital, Calcutta, and is chair in endoscopy committee and CEPOG, and many credentials to his chair. And he was chair organizing committee. Everybody was appreciating AICOG 23 Calcutta, and he's past president of Bengal Obstetrics and Gynae Society, vice president FOXI 2017. And we would like to see sir and obviously he's the choice for our president FOXI. And with this, I introduce.
Thank you. Piyush, if you stop sharing, I will share my screen. Good evening, everyone. And right at the outset, I think I'm thankful to Sneha and Dr. Nutan for inviting me. And it's a pleasure to be among my favorite seniors, Kamal Bakshi Madam, Meera Madam, and dear friends, Bharti, Parag, Dr. Pardesi, and Dr. Somna Madam, Dr. Meenakshi Sood Madam couldn't join, and all of you whom uh, Sneha has already named. So I will just put it on slideshow and yeah. Okay, I will skip this slide, but just to, I think I should say this, that I have been in Foxy leadership positions since 2007 and served the journal, the ICOG international organization, apart from being a committee chairperson and vice president. And I seek your support and blessings for the election to the post of Foxy president. And I will bring you greetings from Kolkata. And I straightway move on to, although the uh, topic is evidence-based cesarean section techniques, I will talk of a few things on experience-based also. And I was very pleased to hear from Kiran Sinha Madam that one of the things I will speak on is something that Dr. Kamal Bakshi also used to insist on. Now, the first thing to start off with is when should you do our elective cesarean section? If there is no other reason, obstetric or medical, to do it sooner, we should not schedule a cesarean section before 39 weeks. And this is because of the risk of transient tachypnea of the newborn. Earlier, we used to say it's 38 weeks. At the present moment, it's been shifted to 39 weeks. I hope all of you know that we stopped giving steroids before elective cesarean section. We only give steroids routinely up to 34 weeks and selectively between 34 and 37. So to avoid the risk of TTN, schedule the sections at 39 weeks and above. Today is the era of enhanced recovery, and part of this enhanced recovery is not to fast the patient for prolonged periods of time. We use preoperative antacids and drugs to reduce gastric volumes and acidity, and preoperative antiemetics. Earlier, we used to use liquid antacids. At the present moment, I think our favorite choice is to use. Can somebody mute Dr. Archana Messi, please? Our favorite choice is using ranitidine and metoclopramide. These two drugs will reduce the acidity, reduce the volumes, and also have the effect of antiemetics. We should offer a regional anesthesia in preference to general. We are not in a great hurry as far as the incision delivery interval is concerned, and it is safer for the patient, and the patient is very much in control rather than waking up from a general anesthesia suddenly with pain. If we do a regional anesthesia, we should always insert an indwelling catheter in the bladder and keep it at least for 12 hours. Till delivery, we should keep the table on a 15-degree lateral tilt. To prevent infection, we should use an alcohol-based chlorhexidine or betadine solution for skin preparation and use a single dose of prophylactic antibiotics before the skin incision. Anytime within 30 minutes before the skin incision. The choice of antibiotics should depend on the local resistance protocol. But the WHO recommends that if you are using an antibiotic which contains clavulanic acid, then we should use it only after clamping of the cord, because we are not sure of what are the effects of clavulanic acid on the baby. Although the use of intravenous tranexamic acid as a prophylaxis has not been well established, there are trials on, but I would strongly recommend to use intravenous tranexamic acid, especially in women who are at high risk of postpartum hemorrhage. Consent is a very important medico-legal document, and the rule of, apart from explaining the procedure in the patient's own language, we need to also write down what is the reason for doing the surgery, what are the alternatives, and what are the consequences of not agreeing to the surgery. We need to talk about complications. The rule of thumb that we should talk about all complications which happen with a frequency of more than 1% and rarer complications which might have a significant impact. So we talk about fetal lacerations, which is around 2%, the risk of infections, which is around 8%, and that includes endometritis, urinary infection, and wound infection. We talk of risk of visceral injury. This is usually if the patient has had a previous history of a pelvic surgery, then the risk is somewhere between 1 in 250 to 500. And the risk of venous thromboembolism, which is approximately about 1 in 1,000. Who should sign the consent? The patient herself. and somebody from the surgical team which is conversant with the procedure. It is a good practice to have two witnesses, one from the patient side and one from the medical side. The skin incision should be a Joel-Cohen's incision and not a Phalanstein incision. A Joel-Cohen incision is a low transverse straight skin incision where subsequent tissue layers are opened bluntly and if necessary then extended using sharp dissection. The incision on the uterus should be on the lower segment transverse. If the lower segment is well formed, then we should extend the incision in a blunt way. And if the lower segment is not well formed, only then we should use a sharp extension. A blunt extension reduces the blood loss, reduces incidence of postpartum hemorrhage and the need for blood transfusion. Now, forceps in cesarean birth should be used selectively and not routinely because we do not know the effect of the forceps on neonatal morbidity. We should always practice active management of third stage of labor and we can give oxytocin or carbetocin or whatever is the local protocol. Never be in a hurry to remove the placenta by manual removal at cesarean section. I know we are always, Madam was telling about people hurrying it up. We need to be patient and remove the placenta by controlled cord traction because this reduces the risk of endometritis. Now, routine exteriorization of the uterus is not recommended because it is associated with more pain and does not improve operative outcomes like hemorrhage and infection. Even for those who actually routinely exteriorize the uterus, I would suggest that when we teach people to do a cesarean section, we should teach them to do it keeping the uterus in the peritoneal cavity, because otherwise those who are used to routine exteriorization, if one day they cannot take the uterus out because there are a lot of adhesions or large fibroid, I've really seen them struggle. So it is necessary to learn intraperitoneal repair as well. How should you close the uterus? I know that everybody is talking about scar pregnancies. Unfortunately, we really do not know that what causes the scar pregnancy. I have a couple of theories which I'll come to that in a moment. But number one is that use a single layer or double layer depending on the clinical circumstances. Even if you use the single layer, it does not increase the risk of postoperative bleeding or uterine rupture in a subsequent pregnancy. How should you close the abdominal incision? We should use a slow absorbable suture. If it is a vertical incision, close it using mask closure. Does the subcutaneous tissue space need to be closed? Only if the fat is more than 2 centimeters. How should we close the skin incision? We need to be very particular about closing the skin incision because that is what patient can see. And we usually use a subcuticular sutures. But if we want to put interrupted sutures, it is better to put sutures rather than staples because staples increase the risk of superficial wound adhesions. At the end of the procedure, we assess the blood loss. We offer thromboprophylaxis after doing a risk stratification. We must give adequate postoperative analgesia. And I would prefer to give something to a combination of two, one narcotic and one non-narcotic. Offer and facilitate early skin-to-skin contact between the woman and a baby. Initiate breastfeeding early. Always room in the baby. It is important to monitor in the immediate post-op period to pick up complications early. We feed patients early. After a regional anesthesia, we feed them as early as 2 hours and remove the urinary catheter not before 12 hours after a regional anesthesia. We mobilize the patient from the next day and send the patient home by 3 days. In documentation, it is very important to have the operation notes, which should include the indication as well as the Robson's classification. We need to write the estimated blood loss that we've checked the count and very important, the sex of the baby and the time of birth. The things that we should not be doing is there is no role of preoperative shaving. In fact, preoperative shaving causes microabrasions in the skin where the bacteria can colonize and causes increased infection. If there is too much of hair, then what we should do is clipping of the hair inside the operating theater. There's no reason to routinely cross-match blood if the patient's hemoglobin is fine and there's no risk factor for postpartum hemorrhage. We do not use antenatal corticosteroids after 37 weeks and need to use judicially after 34 weeks. There's no need to use separate knives for the skin and the uterus, and there is no need to develop a bladder flap because there is one small randomized control trial which shows that with a bladder flap development, there is a longer incision delivery interval, longer total operating time, and more post-operative microhematuria, a greater need for analgesia, and a greater drop in hemoglobin levels. This is a small video. This is a small video where I'm going to just show what we mean by not developing a bladder flap. And you cut the UV peritoneum and take the same incision onto the myometrium. The bladder would go down on its own by the pressure of the Doyens. The only two exceptions to this is when you are doing a cesarean section at full dilatation or when the bladder is adherent. Now, there's a small word of caution. I think we should teach our juniors to do develop the bladder flap before they learn not to develop the bladder flap, because if you don't develop the bladder flap and you are a beginner, sometimes you tend to go high. So I think we need to first teach them developing the bladder flap and then move on to not doing a bladder flap. Please do not clean the uterine cavity with a gauze piece or a mop. Do not dilate the cervix. We've seen large clots passing through an undilated cervix as well. And women do menstruate and pass clots if they have heavy menstrual bleeding without us dilating the cervix. I think I would insist that do not use interlocking sutures. Whether you do 1 layer or 2 layer closure, do not lock sutures. Surgeons would tell you that locking is a bad surgical practice because it reduces the blood supply and it strangulates the tissues. And if anything, the locking, if you have pockets where there are where the blood supply is impaired, that actually could be one of the issues which might lead to a scar niche forming or weak scar forming. The other thing issue we have is that I think people have been doing 2-layered cesarean section for ages. Many people have been doing single-layer closure for 30 years. But in spite of that, we see a huge amount of scar pregnancy only in the last 10-15 years, and it is gradually increasing. So I'm not sure. I think nobody is sure whether 1 layer or 2 layer has a bearing, and there is a study which is now looking at that, and they haven't had any obvious inferences yet. But one thing is, I have noticed that from the time we moved to catgut to Vicryl, the incidence of scar ectopic has increased. Unfortunately, there is no solution to that because catgut is gradually being phased out. But I think it's about thinking whether that is one of the reasons for more scar niche forming. There is no need to close the peritoneum, visceral and parietal. We have given up closing peritoneum more than 15 years back, and I think it takes a lot of courage to change practices if it is serving you well, but we don't close it for 15 years and we do not see any incidence of increased adhesions. The peritoneum heals by metaplasia, where the peritoneum grows from both the sides. And if you actually close the peritoneum, what happens is that the metaplasia happens over the suture line, and that gets a little thickened and fibrous there. Do not routinely close the subcutaneous tissue space unless the lady has more than 2 centimeters of subcutaneous fat, and do not routinely use superficial wound drains. And this is good practice and evidence-based. And it was great to hear Dr. Kamal Bakshi madam also practices the same thing. I always insist that we should secure both the angles of the uterine incision separately and both the angles of the rectus sheath separately. It's a good practice to inspect the tube and the ovary. Always palpate the posterior wall of the uterus at the pouch of Douglas, because one of the rare mistakes that can happen when there's a lot of bleeding and when that one can suture actually the upper flap of the uterine incision with the posterior wall. We've seen people do that. And you will not miss that if you palpate the posterior wall, and we must teach our juniors to do that. It is a good practice to clean the paracolic gutters, but it needs to be gentle. I have always believed in approximating the rectus muscle in the midline, because some women get bad divarication, and if you approximate the rectus muscle in midline, we see less divarication. With suture, I have already spoken about that, when to change the dressing, anytime after 48 hours. Epithelialization is complete after 48 hours, so we can change the dressing anytime after 48 hours. Thank you very much, and I end again with an appeal, and I'm happy to answer any questions if there are. Thank you, Sneha, for the opportunity.
Thank you, Bhaskar Pal sir, for such a precise details of the cesarean section. Somna ma'am, are you there? I would like to you to give the
And we
concluding
have the
remarks.
comments from the chairpersons. Yes, Dr. Somna.
Thank you, sir. It was an excellent talk, and it is always pleasure to listen to you. Precisely every point you have discussed about cesarean, and the learners or those who know how to revise their techniques. Thank you, sir, for this excellent talk. Thank you, sir.
Thank you, Bhaskar Pal sir. I hope we have been able to finish it in time.
Absolutely. I will hang around for another 5 minutes.
And any questions to sir? If anybody is interested, sir has time.
I welcome Dr. Anuradha Khanna, madam, the immediate past president of UPCOG. Welcome, Madam Anuradha Khanna.
Thank you very much. Sorry for being late.
No problem.
Nice
Welcome, ma'am. Welcome.
Yes, welcome.
Dr. Bhaskar Paul's speech, and it was very, very nice, very important, very practical. So I'm very much delighted that you have made such a nice webinar. My best wishes to Dr. Bhaskar Pal for
Thank you,
coming
madam.
Foxy President. Can you, and also to you, Dr. Sneha Bharia, and my best wishes. Thank you very much.
Thank you, madam. Thank you so much. Thank you so much. Over to you, Nutan. Please introduce and invite the chairperson fast so that we can listen to Madam Professor Seema Hakim's speech.
Yes, give me the sharing right so that in the meantime I start sharing my.
You have it, madam. Piyush, can you help madam make her a co-host?
Now, we would like to go to the second part of our academic session, that is the optimizing cesarean section rates. And for that, I have by Dr. Seema Hakim, our esteemed speaker. And for that, I will invite our chairpersons, Dr. Kalpana Dikshit and Dr. Pramila Mittal. Dr. Kalpana Dikshit, would you please introduce our esteemed speaker, Professor Seema Hakim?
Good evening to all my seniors. Now I'm going to say Dr. Seema Hakim. She is Professor Seema Hakim from Department of Obs and Gynae from the prestigious JN Medical College, AMU. Currently, she is the coordinator of Medical Education Unity, Faculty of Medicine, AMU Aligarh. She is also a nodal officer, Regional Resource Training Center, RRTC project, JNMCH, AMU. She is President, Aligarh chapter of ISOPAR. Over to you, madam.
Thank you very much. Can you see my screen?
Yes, ma'am.
Yes, ma'am.
Okay,
yes,
that's great. Thank you to the organizer for giving me this opportunity and considering me for this very technical talk on optimizing cesarean section rate. Dr. Kiran Sinha has already told in a very simple way how to optimize the cesarean section. But when we talk about how technical it is to reduce the cesarean section rate, I will be covering my topic under the heading of introduction, then appropriate approach to interpretation of obstetrics outcome by mode of birth. Why does a non-optimal cesarean section rate matter? What do patients want? How should cesarean birth rate be measured and what is optimal? And selected strategies for safe reduction of the cesarean birth. And all my content are from up to date. So what, like cesarean birth is performed when this method of birth is believed to be more advantageous for the mother and or fetus than vaginal birth. And the cesarean birth rate is reported in various ways. So the overall cesarean birth rate is the number of cesarean birth per 100 live birth. And the primary cesarean birth rate is the number of cesarean birth per 100 live birth among patients with no prior history of cesarean birth. And CDC reports a low-risk cesarean birth rate as number of cesarean birth per 100 live birth among nulliparous patients at or 37 weeks, completed 37 weeks of gestation, delivering a singleton encephalic presentation, what we call nulliparous term singleton vertex cesarean birth rate. This rate is problematic because of the term low risk. which is not defined in the conventional manner as pregnancy without medical or obstetrical complications. So if we see the Indian statistics, there are 24 million births in India in 2021, according to 5th National Family Health Survey, and national cesarean birth rate is 21.5%. But when we see the private sector, this is as high as 47.4%. And if we see this chart, we can see that in Telangana and in most of the states of South, the cesarean birth rate is very high. Telangana is the highest in all the census, in all the National Family Health Survey, and it is more than 60%. Then when we analyze the various outcomes for cesarean versus vaginal birth, researchers should compare the intended birth route rather than the actual route. That means planned cesarean versus planned trial of labor. Since approximately 20 to 30% of planned labor, if we see, they end up in intrapartum cesarean birth, which is associated with higher morbidity than cesarean birth before labor. So when the correct comparison group is used, the high risk for some adverse outcome with cesarean birth reported in some retrospective observational studies is no longer observed. So if we see the effect, downstream effect of high cesarean birth rate, so there are short-term and long-term effects. So among the short-term effects, they are associated with more risk of infection, hemorrhage, injury to pelvic or abdominal organ, venous thromboembolism, and they are also associated with more postpartum pain and longer hospital stay and longer recovery time compared with the vaginal birth. They are also associated with short-term neonatal risk of cesarean birth, which are neonatal respiratory morbidity like transient tachypnea of the newborn and RDS. Then persistent pulmonary hypertension of the newborn, especially if the tachypnea persists for a long time, and more NICU admissions are there. They are also associated with a long-term risk like placenta previa and placenta accreta. If we look back to the literature from 70s and 80s, there were estimated risk of placenta accreta, approximately 1 in 2,500 to 4,000 births, but studies from 2016 have estimated it to be 1 in 272. So every day we as an obstetrician continue doing difficult cases of placenta previa and placenta accreta, many of them landing up in cesarean and cesarean hysterectomy. And if they are not in the safe hand, they are also associated with a very high mortality rate. So other long-term complication of cesarean birth includes, though they are not that common, but we are increasingly, we are seeing those complications like scar dehiscence and scar rupture, and thus and other cesarean scar pregnancy. Cesarean scar pregnancy is the one which later on leads to PAS. So they are all increasing every day, and we have heard our expert and our guest speaking about it in our inaugural function today. Then there are the cesarean section rate should not be very low also. Many people claim that I do not do ever a cesarean section, or I will refrain from doing a cesarean section and conducting all normal delivery, which is not true. So cesarean birth rate below 15 to 20% may be too low. So because they can also jeopardize maternal and or fetal health, or the risk for both may be there. So in 1985, WHO recommended that national target should be 10 to 15%. And a few years back, like in 2000, there was a UN process health indicator. which said that in any healthcare facility, cesarean section rate should not be more than 5%, less than 5% or more than 15%. But what happens now? The WHO did further. They collected the data from 194 WHO member, and they have said that cesarean birth rate of more than 19% were associated with less maternal and neonatal mortality than a lower rate than this. So what do patients want? So if we see most of the patients, they will be wanting a normal vaginal delivery. Only a small minority of 1 to 5% in United States and 3% globally, they will be asking for a cesarean birth, which is also called cesarean delivery on maternal request. So obstetrician, it seems that many times they agree for, if the patient asks for cesarean delivery, they are also scared that if something goes wrong, the patient will blame us. But recently it is said that an obstetrician can refuse cesarean delivery on maternal request, but at the same time, a referral to another provider should also be facilitated by the obstetrician who is dealing with the patient asking for a cesarean delivery. Health system vary widely with respect to population. So, like cesarean birth rate will be variable in different population. How should a careful cesarean birth rate be measured and what is the optimal? Dr. Bhaskar Pal has already spoken a word about Robson. So as like cesarean birth, you cannot generalize in all the cases. So Robson has categorized it into 10 groups, and the group that compares the different indications and outcome in that category only. So the Robson's, 10 Robson's category are, category 1 is nulliparous singleton cephalic more than 37 weeks in spontaneous labor. Then nulliparous singleton cephalic more than 37 weeks induction or pre-labor cesarean section. Then multiparous with no previous cesarean singleton cephalic more than 37 weeks in spontaneous labor. Multiparous, no previous cesarean, singleton cephalic more than 37 with induction or pre-labor cesarean section, and previous cesarean birth, that is TOLAC. Then all nulliparous with breech presentation, that is another category. All multipara, including those with previous cesarean with breech presentation. All multiple gestational pregnancy, all abnormal lies, including those with previous cesarean, all singleton cephalic less than 37 weeks, that means preterm, including those with previous cesarean birth. So the cesarean birth rate, if higher than optimal among some group of patients, is a multifactorial challenge. It is unlikely that a single approach will be effective for optimizing the rate and or reducing the rate in some population. So what we depends on are the trial with level 1 evidence for practice change that can be implemented in all the patients. So what all practices are to be implemented to reduce the cesarean birth? One is ARRIVE trial. Out of many outcomes, they have seen that induction at 39 weeks resulted in reduced risk of cesarean. Apart from that, there was a statistically significant reduction in cesarean maternal and neonatal morbidity, make induction at 39 weeks of gestation an important practice-changing strategy, and has led some to suggest that these are risk-reducing labor induction and therefore should not be called an elective induction. They are risk-reducing induction. Then another strategy is early rather than delayed pushing. Some people will say that patient is fully dilated, unless they have an urge to push, they should not push. But it is seen that though it will not, the early pushing will not affect the rate of cesarean section, but this will definitely reduce the risk of chorioamnionitis, postpartum hemorrhage, and neonatal acidemia. Then another strategy is manual rotation for second stage dystocia with mal position like occipital transverse or occipital posterior position. Trained obstetrician can do a manual rotation, and that will help more for a normal delivery. Then forceps and vacuum assisted vaginal birth or for second stage arrest, especially by trained obstetrician in appropriately selected patients. It is seen that they have a high success rate, thereby reducing the need for cesarean birth. And this will also reduce the risk to fetus also. Like it was said that forceps will lead to some neonatal trauma, but which is not true. In an experienced hand, forceps and vacuum delivery, they are very safe. Of course, in appropriately selected cases. While the cesarean birth rate has been on rise over the last 15 years, operative vaginal rate have declined significantly, leading to a reduction in the number of physicians trained in vacuum and forceps-assisted birth. And many people scare about having a litigation because of which they do not try a operative vaginal delivery. But again, I will say that if your patient is appropriately selected, they will be a boon for your patient and they can have a safe vaginal delivery. Then ACOG has provided several additional strategy for safe prevention of primary cesarean birth, and Dr. Kiran has beautifully said everything about optimizing cesarean birth. What all antepartum and intrapartum care which you can do is counseling the patient regarding avoidance of excessive gestational weight gain, which is associated with increased risk for cesarean birth. Then assessment of fetal presentation at 36 weeks, and if they are non-cephalic, you can do a external rotation to make it a cephalic presentation. Then encouraging a trial of labor rather than planned cesarean birth for patient with cephalic or cephalic non-cephalic diamniotic twins. Many times patients fear that if there are two twins, they will have difficulty in vaginal delivery. Contrary to them, they have an easier vaginal delivery if they are carrying twins, whatever is the presentation of the second twin. Then induced labor, use of, and if you are planning as induction, you can, prior to to induction, cervical ripening should be done 1 or 2 days prior to that for unfavorable cervix, and then the labor should be induced. You can do it with intracervical Foley's or with giving her misoprostol or cerviprime gel, depending on if they are not contraindicated, you can use this. Then many obstetricians are in a hurry to take a decision, but we should allow more than 24 hours for latent phase and administer oxytocin for at least 12 to 18 hours after membrane rupture before diagnosing it as a induction failure to avoid cesarean birth in latent phase of labor. Then updated definition of normal labor progress in first stage and indication for cesarean birth for active phase arrest in first stage. That means failure to progress in active phase, and when active phase more than or equal to 6 centimeter dilatation, which is latest not more than 4 centimeter, but now it has gone to more than 6 centimeter dilatation. Then adequate time that you've given them oxytocin with 4 hours good uterine contraction, she does not make a progress, then only you should decide on to cesarean section. Unless like there is something wrong with the fetus that we can give them a full trial. Then intrapartum fetal assessment, like sometimes some abnormal dressing, some drops are there and we take a decision. But use a fetal scalp stimulation to assess the fetus with an abnormal or indeterminate type of fetal heart rate pattern before resorting on to cesarean birth. Then for variable deceleration, amnio infusion can be done. That will resolve the problem. Then other non-clinical interventions are also important, like childbirth training workshop for mother, nurse-led applied relaxation, like Dr. Kiran talked about it, that she, in antenatal period, she tells all her patient that what is expected. So through the workshop, if you do, you can cater the need of more number of women in your antenatal clinic. Then psychosocial couple-based prevention program and psycho education is very, very important. Then implementation of like guideline. We should follow the guideline and then combine it with audit and feedback. Like Professor Kamal Bakshi has so beautifully narrated her own experience that why cesarean section rate is going down or going up. Through the audit and feedback that we can change our practice. If we are doing more, we can see that why, like she said, that at night most of the cesarean sections are going on because many a times consultants are not around and residents, they take the decision on their own and then do it. Then of course, physician education like we are doing today's CME, it might help people in deciding next time that they go for a cesarean section, that what all things to be done. Then one-to-one support during labor is important. So doula care is becoming more and more popular. So now these days, professional doula are available and one can hire those doula for labor. So who is a doula? Doula is like a trail guide, familiar with the path. She keeps you hiking through the hard parts, knowing the view at the end is incredible. So this is beautiful description for doula. Then labor is about patience. Like again, many people have spoken about it. Dr. Kiran, Dr. Bakshi, they have said that labor is about patience. So one breath, one contraction at a time, and it all matters. Give laboring women time to progress. So however much we know about birth in general, we know nothing about a particular birth. So we must let it unfold with its own uniqueness. And here at this point of juncture, I would like to mention that when we decide about cesarean section in any women, it is always better to take a second opinion. So we should not shy away. Even if we are holding a very senior position, we should not shy away by taking a second opinion of our colleague or even after junior. And junior must take the second opinion of their senior. Whenever you do unnecessary cesarean, whenever you think that you are doing a cesarean section for a right indication, or maybe like not very sure whether my indication is right or not, there is no harm in taking a second opinion. That will definitely help you, your patient, and in general, everyone else will be benefited by taking a second opinion. So according to WHO also, every birth is unique. Some labor progress quickly, others they don't. And we have witnessed it in our clinical practice also, that sometimes, we think that, arey, abhi to isko bahut time lagega, and she delivers so fast. And some people, we predict that, oh, no, she's going to deliver very fast, and she doesn't. So every patient is different, but unnecessarily medical intervention should be avoided if the women and her baby are in good condition. And we should always be supportive during labor, like encouraging words. Like, you're doing very well, come on, keep it up, the baby is going to come out, you're going to enjoy the company of your baby, and I am there to help you. The doctors, the nurses, and her attendant, doula, or even husband is allowed during labor, and everyone is so much encouraging that she thinks that she is doing well. And many a times these encouraging words are very helpful, and tell her to adopt the position of her choice rather than hanging up her on a table we can give her small advices like standing, squatting, sitting, pushing the wall, and these things, they divert their pain and they encourages her to bear down and to deliver normally. And at the end, if you have done your job well, you will get a card from your patient. Thank you for delivering our sweet baby to this world. And if you have made a mess of it, they will be very annoyed. So we want that our patient should be happy. We should be happy at the end. Nobody should suffer, neither the mother nor the baby. Do not ever think that delivery by cesarean section is a very safe route. Let us go for a cesarean section. Later on, they will have more problem, and even you will have problem, because after all, you will have to deal with those placenta accreta and cesarean ectopic pregnancy. With that, thank you very much for this opportunity. I really enjoyed making the preparation for this presentation. Thank you, Dr. Sneha, once more for this opportunity. Thank you very much.
Thank you, Seema ma'am, for such a lucid talk on optimizing cesarean rates.
Yeah.
I would like
We
to
will have the comments from chairpersons.
yes, I would like to take comments from Dr. Alka Sethi ma'am and Dr. Kanchan Sharma ma'am, please.
They are the experts from the panel, but I think
sorry, Dr. Kalpana Dikshit ma'am and Dr. Pramila Mittal ma'am. Yes, Dr. Kalpana Sharma, I can see you.
Is anybody there, the chairpersons? But I would just make few comments that, madam, it was such a wonderful presentation, and I'm sure you really have to go to the all the technical aspects, but you are a such a dedicated professor, dedicated and focused academician. I'm sure over your so many years of experience, you must have gathered all those points very I mean minutely, I'm sure, and definitely the technical aspects you have taken covered very well. Robson's criteria, as you have said, that you have to apply for each and every patient. So I think that itself will guide you, and the trial of vaginal labor, of course VBAC, all these concepts have to be very, very very liberally followed. I would say, of course, the vigilant monitoring definitely plays a role, and as you said, the patience for the patient as well as obstetrician, I think that is very, very important as far as the optimizing cesarean section rate is concerned. I would like to have,
Dr.
if the
Sneha?
persons are not there, I would like to invite, yes, madam. I would like to invite
I
Madam
want to say
Kirti Dubey
something.
also for her comments, and yes, Madam Anuradha Khanna also.
Okay. Very, very nice deliberation by dear Seema. She worked with me in Institute of Medical Sciences, BHU, and she's very dedicated person. And some points I will like to listen from her regarding cord around the neck, because there are some situations where we are still in this thing, whether we should go for elective cesarean section or should we for a trial of labor and with monitoring for the cord around the neck, and what are the litigations may likely to occur. This is one point. Then, as you mentioned already, the pre-labor pains. If she is having pre-labor pains, then we should wait instead of jumping for induction of labor. And I hardly ever seen amno infusion, that whether it should be get it done or it is more causing a lot of infection. Then regarding DOLA, this is only for 10 to 20% population of India who can afford it. Otherwise, just making her comfortable in a moving sitting posture or standing posture, depending how the patient wants to be comfortable, that she should be washed under labor. And this is very important, I think. Then we should have always in our mind the paperless partogram, whether she is a primary or multi, along with her obstetrical and cesarean or operative history. So these things are in my mind. I know, Seema, you know all these things very, very well, and you have practiced it very much, but I will like to listen from you.
Ma'am, cord round neck is not an indication for cesarean section, but it is an indication for a careful watch of fetal well-being during labor. Wharton jelly is enough to take care of any compression which we can expect. But if she has intrauterine growth restriction with cord round neck, maybe she will have some problem. But if we are careful during labor, she delivers, and many cases deliver vaginally who have cord even twice round neck or thrice round neck. So cord round neck is not an
The
indication.
type of cord. The
Then,
type of cord around the neck.
then another thing you said about induction, as per Right trial induction, they have recommended induction at 39 weeks plus 4 days pregnancy, but most of the people may not agree for this, and they let the patient go into spontaneous labor at term. But as per the recommendation, they have said that 39 weeks induction leads to lesser number of cesarean section. Then about amnioinfusion, we are not doing it. But as per the literature, they have said that if there are variable deceleration or there are features of cord compression, amnioinfusion might help in those situations to take care of cord compression. But routinely, as you said, we used to do it a few years back, but we do not do routinely amnioinfusion, thinking that this leads to more infection and more incidence of chorioamnionitis. But I have talked as per the literature, as per up to date data, and as per the study, that amnioinfusion does help. But personally, most of us may not be doing it. And once there are variable deceleration with some prolonged deceleration of bradycardia, most of us will take the patient for cesarean section rather than waiting long, unless she has gone into second stage that we can expedite it. I hope I have answered, or if I missed anything, ma'am, you can.
Thank you so much. Thank you so much.
Yeah. This is the type, this is the cord round, no problem. But if it is like this and then coming out like this, that can be very well visualized in a
evidence-based practice, that is not an indication for cesarean.
Yeah, that is not an indication, but you know, Seema, if something goes wrong, and sonologist has mentioned that it is a dangerous type of cord around the neck, the loops of cord around the neck. So one has to be
But
very
ma'am,
careful.
that we will know
And
in
such
early
cases-
labor. With CTG, we will know that the baby is not doing well because of cord round neck, and we can convert it into cesarean section. That is
And
what
if
is
it is
my
coming
view, and
like-
we practice this way only, that we don't never do it for.
Thank you, madam. Thank you so much, Madam Seema Hakim, for your very exhaustive and informative talk. And of course, Madam Anuradha Khanna, for your discussion of your experience. I would just invite Madam Kirti Dubey for her comment. As you know, Madam is President of UPCOG. Madam, please unmute yourself first. And of course, she's, from US, late night, she's, just joining the webinar. So over to you, madam, for your precious words.
Thank you, Dr. Seema. This has been a wonderful, excellent talk. You have covered, I think, each and everything to bring about a reduction in cesarean section rate, keeping in mind the prevention and of this morbidity, fetal morbidity and maternal morbidity, and I would say mortality too. But one thing I would like to just ask you, as regards, you said that your talk was covering up to date. Up to date says that you should avoid delayed pushing in second stage. But of course, actually what we in India, of course, have been doing, that it is not just full dilatation, it is only when the head comes much lower down below the ischial spines, then only we ask the patient to push. Do you all recommend a very early pushing once cervix is fully
No,
dilated?
ma'am, but most of the time when she is fully dilated, head is also low down. Very rarely it will happen, especially in multi-gravida, that she is fully dilated and head is still up. In primary gravida, definitely head will be down, and then only she has a full dilatation. And what is recommended that instead of delaying the pushing, you can ask her for early pushing. What we recommend in our patient, we like once she is fully dilated, most of the time she will have an urge to push. So like we ask them if they are having an urge to push, what is my experience that most of the time they will have an urge, but we ask them also that whenever the contraction comes, you try to push it. So that suddenly we don't ask you start pushing and then you deliver out, but little push with each contraction, that helps.
Okay. Very nicely covered. You have covered all the topics, and the most important thing, I think, Dr. Seema, is that in our antenatal care itself, we have to keep on counseling the woman and telling her about the stages of labor, and that is how we boost up her morale and prepare her for a vaginal delivery. Thank you so much. It was really an excellent talk, Dr. Seema.
Thank you.
Thank you so much, Nutan. I think we can go ahead with the panel discussion. And just in short, you can invite the panelists for this program, the expert and the panelists.
And the third part of our academic session is the panel discussion on HDP. And I would like to introduce our experts, Dr. Alka Sethi, President from Jhansi, and Dr. Kanchan Sharma from Kanpur, who is recently going to host a national conference. So both of them, please, I invite you as experts. Can I, yes, Dr. Alka Sethi, President Jhansi. Can I have a CV, please? And Dr. Kanchan Sharma, who is the Chief Consultant of Akash IVF Center, Kanpur. So I invite both of you as experts. And now I would like to introduce our moderator, Dr. Sneha Bhuar. We know her well. So, and she has been academically very active and reaching out to all societies. So I welcome Dr. Sneha Bhuar ma'am to moderate this panel discussion on HDP.
Thank you,
Dr. Alka Sethi and Dr.
Dr.
Kanchan
Sneha.
Sharma. Please come. Please, I welcome both of you.
Just my best wishes to Dr. Sneha and Dr. Bhaskar Pal also. And I am a bit busy because some guest has been arrived. So I'll be logging in between, and I may need some excuse regarding that.
Okay, you can invite thank you so much, Dr. Kanchan, for joining, and of course, we'll be happy to have your inputs. Nutan?
Yes, I can see Dr. Alka Sethi, but I'll introduce the panelists till then. Yes, we have Dr. Rakhi Malhotra from Kanpur. Can I have our next thing? Yes, Dr. Roshan Parveen from AMU. Dr. Jayashree Pathak, she is at present from Khora Makhanpur. Now, next is Dr. Tina Sahu from Jhansi. We have Dr. Deepa Saxena from Shahjahanpur. We have Dr. Garima Gupta from Kanpur.
Thank you, ma'am.
Piyush, can you please mute rest of the people?
We have Dr. Anita from Kanpur. I welcome all our esteemed panelists. Over to Dr. Sneha Bhuar.
आप आराम से वेट करिए. अब आपको बीच में ब्लीडिंग नहीं आना चाहिए. अब आपको सीधे वही 28 दिन पे आपका मासिक आएगा, तब ब्लीडिंग.
Piyush, can you mute the rest of the?
ये आपका अभी ब्लीडिंग कब से, कल से शुरू हुई है?
Yes, ma'am, I'm working on it.
Yeah, may I request all of you to mute? Yeah, please. I think Dr.
हाँ, ठीक है, कोई बात नहीं. तो अभी हम आपको सिर्फ एक टैबलेट लिखेंगे, बस वो रोज एक खाना है, उसको मिस मत.
Piyush, can you please mute others? Thank you.
Ma'am, I'm muting, but she's unmuting again.
Okay.
Can somebody call Dr. Archana Mishra? And yeah, so a very good evening to all of you. I welcome all the panelists. It will be difficult, I think.
रोज एक खाते जाइएगा
Ma'am, you continue. I'm talking to her. Please.
Yeah. So, can you see my screen?
तो कैल्शियम
Can all of you see my screen?
Yes.
So, a very good evening, dear friends. This is Dr. Sneha Puyar, and of course, I welcome all of you, Dr. Rakhi Mehrotra, Dr. Deepa Sakina, Dr. Roshan Parveen, Dr. Garima Gupta, Dr. Jayashree Pathak, and Dr. Anita Gautam. I have just read her message, Dr. Anita Gautam. She said there's some emergency and she has to leave. So, friends, I would just give my brief introduction because I don't allow my CV to be read, but then I would just say that all of you know me as Foxy Breast Committee Chairperson, which I was there for 4 years. I was a governing council member of ICOG, and of course, in addition to all this, I'm a very hardworking, hardcore obstetrician with 32 years of experience. All these national as well as individual awards, which Foxy ICOG and all other organizations, they have honored me. It is because of my academic excellence, the healthcare and professional excellence, and of course the community service or social service, and not for singing, dancing, and extracurricular activities. So, of course, we as obstetricians have to be very, very cautious. We have to be very vigilant as far as our patient and the pregnancy outcome is concerned. This is just a quote I would like to quote here just at the beginning, that the Professor Mohammad Fatala, who is the past president of FIGO, he expressed that women are not dying because of the diseases we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. And why did he say so? Because all of you know that hypertension, hemorrhage, and sepsis, these are the 3 major killers of our women. We do have various predictive measures, including the maternal characteristics like age, BMI, his family history of hypertension, personal history of diabetes, hypertension, renal disease, and of course the hypothyroidism. You do have the biophysical and biochemical test which can actually predict you, and of course these are the women you can put on low dose aspirin and high dose calcium. You can definitely try to prevent not only the HDP complications, but definitely the reduction in the morbidity and mortality associated. So in spite of all this, the incidence and the complications associated with HDP is not decreased. And the reason being, we even at this stage are not sure that whether the placenta is a victim of all this disorder or a culprit. All of you know this, that this is the pathogenesis where there is a predisposition of this woman for hypertensive disorders. And this occurs when there is a failure of first and second wave of trophoblastic invasion. The spiral arterioles which are there, the small tiny arterioles, they actually should normally get converted into the permanently dilated sinuses, and of course we should not, they get converted into the sinus. I'm sorry for the disturbance. The placenta, actually this manifests with the maternal as well as fetal effect. So where you have the placenta producing the thromboplastin causing the chronic or low-grade DIC, activation of the renin-angiotensin system, and of course you have the various effects of hypertension, proteinuria, and edema. And if this is not treated, then the patient can land up into complications. At the same time, where you have the placenta, where you have the placenta.
बाथरूम में भी लगा दिया.
Piyush, can I request you to please mute Dr. Kanchan Sharma and Archana Sharma? Or Archana Mishra, I'm sorry. Yeah. So, because of the placental ischemia, there can be fetal growth restriction, and of course the fetal complications associated with it. So without much ado, I think we would straightway go to a case which comes to you. So do we have Dr. Rakhi here?
Ma'am, good evening, ma'am.
Yeah, good evening, Dr. Rakhi. I hope I can see all the panelists. If you can put on your video, that will be great. I request all of you to please put on your video. Dr. Rakhi, can we hear from you that, yeah. So we have this patient, 22-year-old young lady. She is a primary gravida and she belongs to a low socio-economic status. There's no medical illness and there's no significant family history. She's antenatally booked, registered, and she has an uneventful antenatal course up till now. So at 32 weeks, she presents to you in the OPD for a routine checkup, and you find that her blood pressure is 140/90. Do you label this patient as hypertensive, and how do you manage this patient?
So, ma'am, the relevant finding in this is the BP of 140/90. So, to label it as hypertensive or not, it is recommended in pregnancy to take at least 2 readings to label it as hypertension around 4 hours apart. And if it's raised than 140/90, then it is mild hypertensive. And then if it is more than 160/110, then it is severe hypertension.
Yeah, so I stop you here. And we take a good discussion here. So Dr. Rakhi, previously there was a classification of mild, moderate, and severe. Okay, but nowadays the classification has been totally changed. Okay, and so for this patient, even with 140/90, suppose I tell you that you are saying this is a mild hypertension. Now my next question is whether you will start her on antihypertensives.
No, ma'am, not straight away. First, we have to see that this the BP taken 140/90 is correct or not. So
yeah, you have checked it. You said that after 4 hours you have confirmed it also, and now also it is 140/90. Now, do you label her as hypertensive?
Yes, ma'am.
And do you start her on antihypertensives?
Ma'am, first of all, we will advise investigations.
Okay.
Like
you said it is a mild hypertension, right?
Yes, ma'am.
So for mild hypertension, do you want to investigate?
Yes, ma'am. It's 140/90, so we should investigate it. And like basic investigations, CBC, urine for routine, microscopic for proteinuria, and liver function test, kidney function test.
Okay. So you do all the investigations. Then how do you manage? Tell me.
Ma'am, if the BP is 140/90 and if the proteinuria is present, then we can label it as, if proteinuria is absent, then we can label it as a gestational hypertension. And if it's 140/90 with proteinuria, then we can label it, or any other investigations are positive, then we can label it as preeclampsia.
Oh, but the question still remains. My question is only one, whether you will start her on antihypertensive. That is all.
Ma'am, according to recent guidelines, we should always start we can start antihypertensive with a BP of 140/90 because it is recommended that BP should be around 135/85.
Okay. Anybody else wants to add anything? Doctor, I can ask Dr. Roshan Parveen. Do we have Dr. Roshan Parveen?
Yes, ma'am, I'm here.
Yeah,
the recent NICE guideline, according to NICE guideline, it is recommended to start antihypertensive on the BP of, if the patient is found out to be positive for 140/90, 6 hours, 4 to 6 hours apart, we have to start and we have to maintain the target of, as Dr. Rakhi said, 135/85. This is the recent NICE guideline 2019 and amendment at 2023.
Okay. Anybody else wants to add anything?
Ma'am, may I add, ma'am? I'm Dr. Garima.
Please.
Ma'am, actually, whatever is said is more or less correct only. But the thing is that we just have one BP recording of 140/90, and you are saying that after 4 hours also it is 140/90 only.
Yes.
So, ma'am, it could be without any, we have to, take history and investigation as told to rule out whether it is only gestational hypertension, preeclampsia, or it could be, ma'am, even what entity we are calling is nowadays is like white coat hypertension. So, ma'am, because
that's a very reason you are taking it as after 4 hours, no? So the white coat or hypertension is ruled out because you make the patient, you make the patient physically and mentally relax. You counsel her that you not to worry. We're just going to, measure your blood pressure to see that it doesn't make you any harm, and you see that her clothing are comfortable, see that the BP size is good, cup size is good, and her bladder is empty. She hasn't had any of the drugs or medication, right? So this is the ideal situation where you are measuring the blood pressure.
Because we have to start antihypertensive because cutoff of taking the diastolic should be less than 85. Here it is persistent till 90. And ma'am, the thing is only BP itself doesn't, confirm whether she will go into more complications or not.
Yes.
We have to start antihypertensive.
Now you are coming towards the point. Okay, girls, all of you are correct. But to some extent, I would say that, gone are the days where you used to say that once you diagnose the patient with hypertensive disorder, delivery is the only cure. Nowadays, even after delivery, you have what is called as postpartum dystosis. The patient may even convulse during the postpartum period, right? So there is no question of delivery. But the management of hypertensive disorder will depend upon the gestational age at which it is diagnosed, the severity or at diagnosis and the rate of progression, and of course the maternal and fetal conditions, because from this you have to take this pregnancy ahead till salvageability, right? So whenever you have a patient of hypertension, once you confirm, I would ask Dr. Roshan Parveen that what are all the investigations and why do you want to do this? Dr. Garima Gupta is coming closer to the point. I want you to throw some light on this. What investigations and why?
We'll offer the patient investigation. One is blood investigation, then urine exam investigation, then radiological investigation.
Okay.
Then in blood investigation, we'll ask the patient to get us complete blood count done, to look for mainly hemoglobin, to look for hematocrit concentration, then to look for platelet, so that to rule out HELP syndrome, whether cytopenia, basically, because I want now to know that 140/90, it's okay that 140/90, but the patient can have a value of 140/90, but she can land up in preeclampsia, severe or non-severe.
That is what we are asking you, that what investigation and why. You have said complete blood count, okay, accepted. Why you want to do liver enzyme studies, LFTs, why you want to go for KFTs?
Tell you, ma'am. Liver function test to look for the liver enzymes, whether they are raised or not, and that too, whether they are doubly raised or not.
Yes, perfect.
Then kidney function test to look for creatinine, and if the creatinine value is more than 1.1 or a doubling of the baseline previous value, if the patient has got it.
Correct.
So that
So
we
now,
have to look for.
Yes. So now one point only all of you have missed. Though all of you have one by one covered almost 1 point. 140, Dr. Garima is very close. Blood pressure is not the indicator of severity, but you have to ask her for the alarming symptoms and signs. So if she has severe headaches, visual disturbances, flashes of light, if she has upper abdominal pain, maybe her urine output is little going down, then of course she can be a high risk patient. If at all you find that her reflexes are brisk and there is epigastric tenderness, she is at risk. And then of course when you have the impairment in liver and renal functions, then she can be at risk. Now Dr. Garima, once again I come to you, that would you like to hospitalize this patient, and now would you like to start her on any antihypertensives? Now you start, and what are the choices or options for you?
Ma'am, we won't be admitting her because we can manage her in outpatient only, because ma'am, she has told.
Then how do you decide that? That is what. Once suppose you do the investigation and you find the liver functions are impaired, the kidney functions are impaired, would you not admit her?
Yes, ma'am. Because ma'am, we don't say mild symptom or moderate symptom. We say preeclampsia with non-severe symptoms, and the one that you have told with severe symptoms.
So it is very simple nowadays. Severe or non-severe? That is
Exactly.
what I wanted to tell you,
Yes.
that it is not the blood pressure, but the features of severity. So here it is severe and non-severe. Okay, no, not mild, moderate, severe.
Exactly.
So
So
you are clear.
yeah, if patient develops preeclampsia with any of these symptoms, then we have to do inpatient management. Also to depend upon the gestation age also, ma'am. If this patient is only 32 weeks,
Suppose she has a
follow up.
severity features even at 26 weeks, would you not hospitalize her?
Said, ma'am, it depends upon age also.
Yeah.
And
so gestational age is not the criteria for hospitalization. It is a criteria to decide about the management. Okay. So all of you have said this, that these are the investigations and you are doing it for this reason. Proteinuria is again not an indicator of severity. Only one thing Dr. Roshan has missed, this is, even on peripheral blood smear, you can make out hemolysis. A very simple test which can tell you the gravity of the situation. Okay.
Ma'am, apart from the things IHSSP has added one more thing of doing saturation also according to the Pyers model. This was the only extra thing that I got by reading, ma'am.
Yeah. So
because
we come back to the same point. Yeah. We come back to the same point now that all of you. Yes, yes.
Yeah.
Who is talking?
Ma'am Garima. I was saying.
Garima. So yeah, I think I'm not able to. All of you can pin up yourself. You make a pin so that I can see all the panelists. Now I'm missing out so many, almost more than 50. They joined. So Dr. Jayashree Pathak. Dr. Jayashree, please unmute yourself. We want to know from you.
Yes, ma'am.
Actually, it is not nice, mind you. It is not nice. NHS 2010 said that, it should be 150, 100 when you should start antihypertensive. Then
Yes,
it is who? Which guidelines say that you should start antihypertensives at 140, 90? And what is the reason behind that?
Ma'am, initially, as you are right, initially what actually was promoted was that you start antihypertensive only when the BP is more than 160 and the diastolic is more than 110. But then over
No. Start antihypertensives is 150, 100. That was the dictum by NICE. That was the guidelines by NICE. Okay. You're talking about severity, mild, moderate, severe. That is the same. 140, 90, 150, 100, 160, 110. That is how it was mild, moderate, severe. But when you start antihypertensives, the NICE guidelines in 2010, it said that, you should start antihypertensives on 150, 100. That means systolic 150 and diastolic 100. But yes.
And then in 2018, a Cochrane came and they also said that start antihypertensives in mild to moderate hypertension as well. And then NICE in 2019 again came.
We are not following that mild to moderate hypertension. That classification itself has gone. It is severe and non-severe.
Yes,
right? Okay. So you talk about the systolic and diastolic. We accept your whatever you say.
So, ma'am, then in 2019, NICE said that, okay, if it is more than 140, 90 also, then you start antihypertensive.
So that is NICE 2018 and World Justice Organization and FOXI ICUG.
Yes, ma'am.
And International Society of Hypertension says 130/85.
Yes, ma'am.
Okay.
Now they want to aim it as 135/85.
Okay. Now you tell me what are the options available for this kind of this type of blood pressure 140, 90. What antihypertensives you have all the options and which one you will prefer?
Ma'am, easily the safe now which is recommended and as a private or
first we want to say options. What options are available? Then you
labetalol is the
labetalol, nifedipine.
Labetalol is the number one. Nifedipine definitely second, but it is not promoted because it decreases the blood pressure very fast sometimes.
No, there is a what is called as there is a preparation called as retard. Okay, do you know that?
Yes,
Cardia retard. Yeah.
But still, ma'am, labetalol is the first, then is nifedipine and the methyl dopa, which we used to use very early.
Okay.
Now it has come in the number 3.
At present, we will accept that only we have 3 options: alpha-methyl dopa, nifedipine retard, and labetalol. Because you have to prove it's not one superiority of one over the other. There are certain indications and contraindications for each. Okay. Now you tell me that why not alpha-methyl dopa? Now we can take from, I think, Dr. Rakhi Mehrotra. We can go with you that why not alpha-methyl dopa?
Ma'am, alpha-methyl dopa was used for a long time, and we know that this is safe drug for mother and baby. But this is a centrally acting alpha-2 adrenergic agonist, and it acts by depleting sympathetic outflow, so it causes dizziness and lightheadedness more often, and it also causes depression.
Dr. Rakhi, I would request you to speak in front of the camera because we're not able to hear you. Right. So, do we have Dr. Tina?
Yes,
Do we
ma'am.
have Dr. Tina? So, we don't want
Yes,
to
ma'am.
put any of the panelists, please. So, he
Yes,
said
ma'am.
that history of sedation, history of, dizziness because of the alpha.
Yes.
Anything else you want to add
Ma'am,
for
alpha-methyl dopa is not
causes
available now, and it caused delayed decrease in blood pressure, and
the onset
it
of
was
action takes almost 24 hours.
24 hours, yes. And after 24 hours, it caused sudden
Yes.
hypertension.
So that is
And
very good because
that caused a postural hypertension and
correct. So I am sure even Kirti madam is here. All of us have used alpha-methyl doma in and out almost, but the dosage required was 1 TDS, 1 QID, maybe 2 TDS and 2 QID on day 1, and it will not have any action. Suddenly, the next day, the patient will have hypertension. The moment she gets up from bed, she will fall down. Okay, so that is how the postural hypertension was a major drawback of this drug, right? Okay, and because she was having some psychological effects, also depression, sedation, and there was some more problems with this alpha-methyl dopa. That there was the false non-reassuring fetal heart recordings also was a problem with this, because the mother was sleeping all the time and she will not perceive the fetal movement. Also, it is to got so severe headaches that we used to get confused whether she will throw a convulsion now or it is because of the alpha-methyl dopa. So that is what is one problem, and that's a very reason. And of course, Dr. Tina has said that it is not available. It's true that in majority of the places it is not available, though previously it was available as 250 milligram and then later on as 500 milligram. Okay. So now why alpha-methyl dopa? I would ask you once again, Dr. Anita is not here. Garima, I can ask Dr. Garima. Why?
Yes, ma'am.
Why labetalol? Why do you prefer labetalol?
Ma'am, first of all, it's nowadays it's easily available. Its onset of the onset of action is very less, around 30 minutes, ma'am, I guess. And ma'am, side effects are very less. The only contraindication of using labetalol are like few, like we can't be using CHF in case of asthma and in case of bradycardia. That's why, ma'am. And also the fall in BP is not that,
Yeah. So somebody was trying to say that I think that was this Dr. Jayashree Pathak, that it was labetalol which is superior and first drug of choice, or is it Garima? So if you have equal efficacy of tablet Nicardia retard and labetalol. The only difference here is if you have severe tachycardia and if you have severe headache, you will not prefer nifedipine because these are the drawbacks. For this patient, you will prefer labetalol.
Yes, ma'am.
On the other hand, if you have severe bradycardia or maybe the congenital heart blocks or CCF, asthma, as you said, then you will not prefer labetalol and you will prefer Nicardia. Okay, so very simple for this, non-severe hypertension.
Well, also, ma'am, what happened with Nicardia that we had been using earlier, like sublingual, that used to cause sudden hypertension. That is not, that
I will tell you that is not Nicardia retard.
Yes, ma'am, that is
there
plain.
are two types of formulations.
Yes,
One
ma'am,
is
yes,
the
ma'am.
retard formulation, which is a slow
Yes,
acting. It's a tablet. And what
Yes,
you
ma'am.
are talking about is what is called as
Yes, ma'am. That's why what used to
Okay,
happen now in CMOG training also, now, ma'am, because we teach the the MBBS students and also the basically the periphery doctors, we don't
Yeah.
ask them to straight away give basically the nifedipine, because they still prefer to give sublingual. So, ma'am, it's easier to give labetalol, which is nowadays readily provided by the government.
No,
so, ma'am,
once
that's
again,
why
I'll clarify your confusion. Tablet
Yes.
Nicardia retard is a retard preparation, which is a slow-acting preparation.
Yes, ma'am. Yes, ma'am.
And
Definitely,
what you
definitely.
are talking about is a orange color capsule.
Yes, ma'am.
Yeah, so we are not talking about that orange color.
We have not give it.
Yeah.
We cannot give that at all.
Yes, that is what I'm telling you, that we come to it when there is a severe hypertension.
Exactly.
So for 140/90, we have three options: alpha methyl dopa, tablet Nicardia retard, and tablet labetalol. Okay,
Yes.
so this discussion is enough for us. I would ask Dr. Deepa Saxena, what is the role of bed rest and salt restriction?
Bed rest and salt restriction or sedatives have no effect on the course of disease. We used to give it in the early phases when we were evolving the treatment of hypertension, but it is not recommended these days and has no effect on the course of the disease.
Yes, in fact, it may have some detrimental effect, because if
Yes.
the patient has, severe strict bed rest, then she may land up into,
Thromboembolism.
sort of coagulopathy and maybe thromboembolic phenomenon, right? And not salt, it will not be strict avoidance of salt, but it will be, avoiding the extra salt. She should not
Extra
take
salt should be
extra salt.
avoided.
Yes,
Yes.
that is how it should be. So friends, as all of you thought, I have to say this here, as all of you thought this is a mild hypertension, this obstetrician was from a previous generation and she thought it's a mild hypertension, 140/90, go home, my dear, nothing will happen. And if at all something happens, I am here. Okay, so challenges are what makes life interesting, and overcoming them is what makes it life meaningful. So this lady was, brought to the relatives 5 days later, because she was not put on any antihypertensive, because as you said, nice guidelines previously, they said only 150, 100 and above. So this lady was not started on antihypertensives. Okay. Now, after 5 days, she was brought to the hospital with severe headaches, nausea, upper abdominal pain. When you examined, the BP was 170, 110. The reflexes are brisk, and she had epigastric tenderness. Dr. Roshan, may I know what is your diagnosis at this stage and how will you manage this patient?
Because this patient has now come back with a BP of 170, 110, and she is giving complaints of epigastric pain and ghabrahat like this. So it is more in favor of severe preeclampsia rather, because the BP has risen more than 160, 110. So I will immediately I'll admit this patient. I'll give supportive treatment as well as the magnesium. I'll start with antihypertensive and I'll give magnesium sulfate.
Okay,
so
correct.
that I don't have any. She doesn't land up in convulsion. So
Right.
this is how, and all the basic investigations I will send.
So because this patient has got, all the alarming symptoms and signs, here you have to give magnesium sulfate. But suppose your patient has only 170, 110 or 160, 110 BP and her reflexes are not brisk, or she doesn't have any alarming symptoms and she's only 32 weeks. Would you like to give her magnesium sulfate, or would you like to try and avoid, because you want to continue this pregnancy, she's only 32 weeks. Then suppose, what is your opinion on this? She doesn't have alarming symptoms and signs, only there is a rise in blood pressure.
No, I'll give immediately labetalol, IV labetalol, I will give her. Then
Yes.
I'll
Here, what are the options for you?
Then at this point, I have to decide whether I have to continue with the pregnancy, or I have to decide regarding the termination of the pregnancy.
Yes.
So this
How will you do that?
Maternal surveillance and the fetal. So maternal, I'll give injection labetalol and I'll
Hello? Hello?
For interruption.
Hello?
Hello. Yes, sorry, ma'am, there was some interruption. So I'll redo for the BP. If it has, then I will again monitor her and her BP. simultaneously, I'll keep on
Piyush,
talking
can
about
you mute rest of the members on the panel?
and
Okay.
simultaneously, I'll
What investigations you want to do? All of you, three, only the panelists, please keep your mic on. One who is talking. Yeah, please go ahead. Dr. Roshan, how will you decide whether you can continue this pregnancy ahead or you have to go for termination and induction or delivery?
Ma'am, here I just want to highlight that she's 32 weeks. So we have to give the steroid cover whether we are...
No. The question is, how will you decide? Yeah, so Roshan, I think, yeah, you have logged in with 2 devices. That's the reason there is little echoing. So now I think it is comfortable. You just said that, how do you decide whether you want to go ahead or you can go ahead? How do you decide that? No, you have to unmute one device at least. No, you are not. You are not. You are muted.
Okay. Okay. Am I audible now?
Yes.
Okay. I will give immediately BP is 160, 110. I'll give injection labetalol and I'll look for the blood pressure and simultaneously I'll be inquiring
there's some
with the
problem.
investigation and all the impending
Yes,
features
perfect.
and per abdomen and the fetal surveillance.
Yes, whether she has had end organ
And the
damage or
fetal
no.
surveillance
If
as
she
well.
has end organ damage, you have to control her blood pressure as soon as possible and go ahead with the delivery. If she has no end organ damage, you will just control her slowly, and you will not give her magnesium sulfate preferably, and you will try and conserve this pregnancy or continue and go ahead. If at all you don't give antihypertensives, then she will land up into all these complications. She may throw a convulsions, there can be intracerebral bleed, there can be myocardial infarctions, pulmonary placentae, all these things. Okay. So Dr. Garima, what are the options for the severe hypertension? What are the antihypertensives you use for severe hypertension?
Ma'am, we can give her the drug of choice, mostly is IV labetalol, ma'am. Then the
what are the options first? What are the options?
Yeah, ma'am, IV labetalol, then we can either give hydrolazine or we can even give nifedipine. These are the three.
Oral, yes. Now you are nifedipine there.
Ma'am, even the cardio people, like what we sometimes we give NTG those infusion, but that is not mostly we don't give. The cardiology people give, though we have been trained with that also. But when labetalol 80 to 90% effect is always there, more or less is there. If it's not there, then we go up. Ma'am, and in this case, ma'am, like with 160, 110 and 32 weeks, won't we be giving magnesium, the seizure prophylaxis? I just wanted to ask if she is developing the severe symptoms.
That is what initially I clarified. If she doesn't have alarming symptoms and signs, right? If she doesn't have alarming symptoms and signs, you just give antihypertensives and you see what your laboratory investigations say. If they are indicative of end organ damage, then of course you give magnesium sulfate and you try and prepare her for deliveries. To give steroids to magnesium sulfate. But if it is only the severe hypertension which you are managing effectively with your any of these drugs, then if she becomes stable after that and your investigations are not, impaired, there is no renal or liver function impairment, you can pull this pregnancy ahead. So if you give magnesium sulfate, it becomes a compulsion that you may have to go for, termination or induction.
Also, we have to do fetal monitoring also, because we don't.
That is what. So end organ damage includes everything. You have to assess the mother. So maternal and fetal monitoring. Correct?
Exactly.
Okay. So tell me, Garima, we continue with you, that you have already said these are the options for antihypertensives. What is your aim? How fast do you want to bring down the blood pressure and how much do you want comfortably?
Ma'am, first of all, we don't have to bring down the BP very enthusiastically. What happens when we are newbies, we want to make it as normal as possible. If like the BP is 160 or more, we give more importance to diastolic pressure than to systolic pressure. Our aim is to come to 85 diastolic, but at least,
slowly, gradually. Yes.
Yes, ma'am. So that's why we have to monitor, ma'am. And
Yes.
also, if it comes to normal level, we have to decrease. We can decrease also the dose. It doesn't we have to continue at the same dose. That's why intensive monitoring is very much required, ma'am.
Correct, correct.
So,
So your aim should be the reduction in
for
the
the map.
mean arterial pressure by 15 to 25%. If it is 170, 110, bring it down to 160, 100. Then
Exactly.
next step maybe little lower,
Exactly.
see that everything is fine. Then you try to get it to 150, 90. And
Yes,
there is
ma'am.
no absolutely need that she should go for 130, 85.
Exactly.
You can maintain the patient on 150,
Yes.
90
Yes,
because
ma'am.
you really want to take this pregnancy ahead without any fetal jeopardy, because this fetal circulation now is adapted to this high blood pressure.
Exactly.
So if you bring it down to a significant level, in fact, there will be the impairment in the feto-maternal or the uteroplacental circulation, and that is why
Increase the pressure. The chances of hemorrhage, brain hemorrhage is also there, ma'am. Either
that
it could
is
be
what we
ischemic
said, intracranial hemorrhage. I showed you this list of all the complications, where including hepatic rupture and myocardial infarction, anything can happen, and that is why you should bring down the blood pressure at least to less than 110 diastolic. That has to be taken care of first, right? So the
Yes, ma'am.
principles are very, very clear. That you have to bring down the blood pressure. These are all the drugs what you have said. This is the dosage. If at all, I think I would request Dr. Jayashree to take up what is simple regime for nifedipine, capsule nifedipine. How do you use it? What warning you want to give, as Garima has said already? Dr. Jayashree, can you please unmute yourself?
Yes, ma'am.
Yeah.
So, ma'am, initially we start with 10 milligram orally. And then we have to repeat the blood pressure after 30 minutes, whether it has come down or not.
Yes.
Then we can again give 10 milligram.
Okay. If it has come down significantly, there's no need, right?
No need. Then there is no need.
Because, for capsule nifedipine orally, the onset of action is within 5 to 10 minutes. And the peak effect is at 30 minutes. The duration of action is 6 hours. So you may have to repeat the capsule nifedipine every 6 hourly, maybe. Okay, right. But of course, you have to keep monitoring the blood. And of course, the alarming symptoms and signs, including the urine output, everything. Only, of course, you have to give a warning, what doctor, all of you know well. You have to tell your residents that never we want sudden reduction in blood pressure. So why do you at all think of giving sublingual? In fact, you have to, tell them this way, that we don't want to reduce the blood pressure fast. We just want that it should not go beyond 110, and that is why we want to give orally. So if you reduce the blood pressure suddenly, mother will collapse and the fetus will be at problem. So never ever give. So that is why there is a sign. I think I have made this. See? Okay.
Yes, ma'am.
Yeah. So
keep a pulse rate on continuous tachycardia. We have to monitor.
Yeah, definitely. And then you have to, of course, keep a watch on the alarming symptoms and signs. Now, can somebody talk about hydrolysine? Anybody has an experience in using hydrolysine, IV hydrolysine? Because it is quite commonly available nowadays.
No, yes, ma'am, not
It
easily
is available
available.
as 5 milligram, and you have to give initially as 5 milligram intravenously, and you can repeat it every 30 minutes if needed. Okay, initially give 5 milligram, wait for 30 minutes, see if you have the desired effect, no problem. If at all you don't have the desired effect, you can repeat it after 30 minutes. The maximum dosage you can give it is 20 milligram intravenously. Okay, and that is why 5, you can repeat one more 5 or maybe third times. That is how it is definitely very effective, but as I said already, that it increases the risk of sudden hypotension, which we don't want. And that is the reason we don't prefer hydrolysine. Only in malignant hypertension or hypertension which is refractory to all these drugs, right? Only for malignant hypertension and hypertension which is refractory, not responding to all these drugs, then only we should think of hydrolysine and of course NTG infusion, what all of you know this. There is one more drug, I will just name this, not the theoretical aspect, we don't want to discuss this, nicardipine. is also one more drug. It is also from the same family of second generation dihydropyridine, and it is a calcium channel blocker, almost 100 times more soluble than the nifedipine, and that is why it is also available as injectable form, which the intensivists and physicians are using. We obstetricians are not well versed, so we won't discuss much. There's also esmolol is one more antihypertensive, which is also ultra short acting for, just when you require in that phase where it is very severe. So little quick effect you want to give, but this is ultra short acting. It doesn't remain there in the circulation. You can use your drugs for maintenance. That is what is esmolol. And of course, I would ask Dr. Jayashree Pathak, now that your patient has landed up into severe hypertension, that is hypertensive crisis, she doesn't have, end organ damage, suppose. You want to take this pregnancy ahead. So as you rightly pointed out that you have to do the maternal and fetal monitoring. So what are the, what investigations you want to do for the mother and fetus? And what are the findings in those investigations which will compel you to induce her or deliver her?
Ma'am, clinical findings we have already discussed, like the blood test and all the parameters which are coming. Apart from that, we have to keep on asking for any overt symptom of severe headache, any blurring of vision, any upper.
That she has suffered already, and we have brought her up from that.
Now I will, apart from the maternal test, I will send her for an ultrasound Doppler, and there I have to see what is the growth parameters of the baby, along with the Gleicher and the Doppler studies.
Yes, that you are doing weekly, and that is, so you are doing it weekly. That is the reason you could pull her on till now. Okay, but suppose what are the adverse findings that will compel you to deliver her?
There is reduced or absent end diastolic flow, then I will emergency try to, I mean, because she's now 34 weeks, at this time I have covered.
We have given her steroids and magnesium sulfate.
And now I will deliver it if these Doppler findings come.
Yes, perfect. So you can see here that if it is, there are fetal and maternal indications. So if the mother lands up into eclampsia, you have to deliver her. If the mother develops abruptioplacenty, you have to deliver her. If she lands up into HELLP or acute renal failure, correct?
Yes, ma'am.
And of course, for fetus, absent or reversal of end diastolic flow. These are the, parameters which compel you to deliver her or interfere. Okay, what is the role of prophylactic magnesium sulfate? Dr. Anita, we don't have. So Tina Sahu, Dr. Tina Sahu. Yes, Dr. Tina, and of course Deepika, we will go.
Okay. Yes, ma'am.
Please go ahead. What is the role of prophylactic magnesium sulfate? What do you mean by prophylactic?
Prophylactic magnesium sulfate is given when in pre-eclampsia, where conversion is not present, and to prevent the land the patient into the eclampsia, and also protect the brain of the preterm baby.
Correct. So you are right that prophylactic is to prevent the conversion. That is one, and one is neuroprotection. We perfectly agree with you. I would just ask you, what is the difference between the dosage of prophylactic and therapeutic? Or they are the same?
They are the same, actually.
Perfect.
They are the same.
So I think even if you don't say anything, I am happy, because the word prophylactic, some people feel that you just give 2 grams and sit and relax. So it is not so. Even though it is prophylactic, the dosage and schedule for prophylactic and therapeutic is exactly the same, whether you use Zuspans regime or you use the Preacher's Maxwell regime. Now, can somebody talk about the Zuspans and Preacher's regime? If at all you can take up, very good.
In Pichard regime, there is a loading dose of 14 grams, and then after maintaining dose. In loading dose, there is a 4 gram given in as 20% IV in 15 to 20 minutes, then 5 gram deep intramuscular in both buttocks. And then in the maintenance
So 4
dose,
gram, how do you give 4 gram? How do you give 4 gram? How many
4
ampoules?
gram, 4 gram is 50% magnesium sulfate, which is diluted in 12.
1 ml is 1 ampule is how many ml?
4 gram is in 1 ampule, 2 ml is there.
Yes.
And which is 1 gram.
50% 2 ml is 1 gram. So 1
Yes.
ampule is 1 gram. So for 4
1
gram, you
gram.
have to take 4 ampules.
4
Okay.
ampule and diluted in
So that
12
is 8
ml
ml.
of which is 8 ml total, diluted in 12 ml of normal saline, and then infused in 15 to 20 minutes.
Correct.
And then in maintaining dose,
what all things you, I mean, how do you continue the regime, for how long, what all things, what parameters you monitor?
After loading dose, we should check for the magnesium sulfate toxicity. For this, we check the knee jerk reflexes, deep tendon reflexes, and respiratory rate, and urine output, which should be more than 30 ml per hour. And if any parameter are disturbed, we abandon the dose of maintenance dose.
Only
And
that particular dose of the schedule.
yes.
Only that. And if next time
Next, after 4 hours, we repeat all the things, and if they are present, then we continue the maintenance.
How
Yes.
long?
For 24 hours.
From
delivery of the patient.
Or the
baby,
last
sorry,
convergence.
delivery.
Sometimes she delivers and then again she throws a conversion. So it is not from the delivery, but delivery or the conversion, whichever is later. Okay?
Okay, ma'am.
That. So can somebody talk about Zuspan's regime, which we use for neuroprotection nowadays? I would ask Dr. Deepa. Dr. Deepa. Do we have Dr. Deepa Saxena?
Yes.
Madam, please. What is the Zuspan regime, which we also use for the neuroprotection?
In USP regime, we give loading dose of 4 milligram.
4 gram,
in
madam. 4
yes,
gram.
and yes, and make the volume 20 ml with the magnesium sulfate, and it is given over 20 minutes.
Okay.
Then maintenance dose is by infusion pump, dissolve 5 gram in 500 ml, and it is given 1 gram per hour.
Correct. So
by the
100 ml
infusion
per
pump.
hour. Okay.
By the infusion pump.
And how long?
24 hours.
Correct. It is again the same 24 hours from the delivery or last conversion, whichever is later. That is also same for eclampsia, and this is the same regime which is used for neuroprotection. Now only one thing, because we have this waterlogging for this patient, you have decreased intravascular volume and extravascular volume compartment is very high. So to avoid the waterlogging or the restrict the fluids, we have 100 ml IV mag nowadays, correct? In 100 ml, you have 4 grams. So you have to give 25 ml per hour. Okay. So IV
Ready-made solution is there.
Yes. IV mag is a preparation.
IV mag is a ready-made solution.
Yes, that is what we are talking about. Now, Dr. Rakhi, do we have Dr. Rakhi Malhotra? Yes. So you are, you have managed the patient who was in hypertensive crisis. You have stabilized her. You have given everything, and now you are trying to just push her up. How much she can go ahead. So mother is stable, and even the fetal parameters are good enough. There's no decrease in the diastolic flow. So how often will you repeat the investigations, and at what gestational age would you deliver her?
Ma'am, the blood investigations should be repeated twice a week. All the blood investigations like LFT, renal function test, CBC, platelet count.
But if there is significant impairment,
for
then you have to
investigations
repeat every day. Every day. Yeah.
And in ultrasound should be repeated, like individualized treatment. Ultrasound should be repeated weekly or in 15 days. And NSP should be done alternate day.
Okay. So at what gestation age you want to deliver her?
Ma'am, like this patient is of severe preeclampsia, and we have stabilized this and we have also given corticosteroids. So we should deliver her by 34 weeks.
Correct. So 34 weeks is the acceptable period of viability or salvageability, I would say. And that is what should be our aim, because she has gone through severe hypertension, If she was non-severe, then we could have taken her up to 37 weeks. Okay. So this is what, this is a generalized dictum, what Justice said. If it is less than 26 weeks and the patient has severe hypertension, just to stabilize this is only for information. This is not a part of this case. Less than 26 weeks, there is no future of this pregnancy. You stabilize the mother and go for termination. But nowadays also there is, a lot of controversies here. You can give all this neuroprotection with Maxelf and steroids, and you may have the NICUs, which can save such kinds of babies. That is what is the argument. 26 to 34 weeks is the, the case which we have followed. So naturally you go for expectant management, stabilize the mother fetal, and at any maternal or fetal indication, you deliver her or try to take her to 34 weeks and then you deliver. If it is more than 34 weeks, definitely you just stabilize the mother and go for delivery. Okay. So I would just tell you that this patient, she was receiving all the medications and she was well stable. And she suddenly, one day again, she developed she continued to have severe headache. And she again started developing pain in abdomen. And, when we examined her, suddenly her blood pressure shoot up to 170, 110. Uterus become tense tender. The fetal parts were not well felt. Fetal heart was only 110. And there was altered bleeding, and the os was only 2 fingers. There were no uterine contractions. Only the uterus was tense and tender. Station was high up. So what is the complication which has developed here, Dr. Roshan?
Abruptio placentis.
Yes, abruptio placentae. Okay. So this patient, we further investigation. So we did ultrasound to confirm. Actually, there was a large retroplacental clot of 200 ml. The fetus was still live with fetal heart of 100 only, and the coagulation profile was like this: platelet count 50,000. The fibrinogen was only 150, and the FDP were present. Now, what is your diagnosis?
Lending into help.
No, madam, how we can say help? We don't have the liver enzymes report. She's landing into a DIC because of abruptio. Yes, yeah. So she's landing up into a DIC because of abruptio. Okay. So naturally what you have to do, cervix is not favorable, so you have to take her up for cesarean. Cervix is not favorable, that is not the reason. But she has developed abruptio placentae, for which you have to take her up for emergency cesarean section. Now you tell me whether you will arrange for blood and blood products first, or you will take her up for cesarean section first. Who will take up these questions? Dr. Rakhi?
Ma'am, ideally we should take her up for cesarean section first, and in the meantime we can arrange for blood products.
But she's already in DIC. At least we should try and arrange for the blood and blood components.
Arrange blood products and blood first.
Make sure that we are getting those blood products, right? Blood and blood components. And then you start with aggressive fluid resuscitation, and then you give maybe vitamin K and tranexamic acid, whatever you can give possible. Okay, during
at this time, at this moment, I'll arrange for the blood and the blood product, and simultaneously I'll plan to do ARM, so that I stop that process, ongoing process of abruption going on there in the uterus.
Yes.
And then meanwhile, looking at the fetus condition, I will shift the patient to OT, because might be that ARM will incite, and plus in severe preeclampsia and in this severe preeclampsia patient, the Bishop's score, they behave more than we add plus in the Bishop's score. Right. Because the finding, because of the prostaglandins and all, and because of that bleeding, their Bishops are better than as compared to a very normal patient who go into labor.
So maybe you can say the myometrial irritability. Maybe because of the extravasation of the blood into the myometrium. The myometrium is so irritable that, she progresses very fast. Okay, but then of course you have to make sure that you're getting the blood and blood products. What precaution do you want to take when you are taking this patient for cesarean section? About the preload, the anesthesia? Yes, Dr. Roshan.
The anesthesia, I'll inform the anesthesia patient, anesthesia people about the patient, that what type, and I'll look for chest also. What are the features in the chest, whether she has landed up in, whether the features of edema are there or not. And I'll ask and I'll tell the anesthetist people about the condition of the patient, the BP, the abruption going on, the patient has landed up in the DIC. So mostly epidural regional anesthesia, because the platelet is also less. So
yeah, but see, what I would say, what you are trying to plead, that if she has DIC, she will bleed when they are giving the regional anesthesia. But platelet count of 50,000 and BTCT normal. That is what your argument should be, that she will not bleed. So best possible anesthesia is regional anesthesia. Preferably the epidural anesthesia. Okay. Otherwise, if she has DIC frank and if she has bleeding tendency, then they have to go for the general anesthesia and not the spinal anesthesia.
And if the chest is clear, then they can go for general anesthesia.
Correct. But we should prefer the regional anesthesia because she is not into frank DIC, it is just early DIC. And that is what you decide with this. That is what you decide with this score. Here you consider the platelet count, the fibrinogen markers, the time, and of course the fibrinogen, right? So all these. Somebody is. Can you please mute that person? It will be great help. So if it is less than 5, it is non-overt DIC. And if it is more than 5, then it is overt DIC. So our patient is definitely less than 5, and that is why we can go ahead with the regional anesthesia. So everything was confirmed, and she was taken for cesarean section. What oxytocin you should give for this patient?
For this patient, oxytocin should be given as a oxytocin should be
anything else, anything better than oxytocin you feel?
And carbetocin can be given.
Some can be given.
So if you give, prophylactically, carbetocin works only when given prophylactic, mind well. Once you give her oxytocin, all the receptors are utilized by oxytocin and carbetocin doesn't work, okay? So you have to give carbetocin as a prophylaxis, correct? One shot of carbetocin is very, very effective. It is equal to 8 to 16 hours of infusion of oxytocin, correct? Now why I'm saying this? Because your patient has abruptio placentae, she may develop cuvular uterus, she may land up into atonic PPH, and already she is into early DIC, so she's going to bleed, that is for sure. So you have to make all the preparations to see to it that she effectively contracts. At least there should be no atonic PPH, because the DIC part will definitely make her bleed, right? So you have to give her, as I said, vitamin K, tranexamic acid, 1 full gram, that you have to give. And then of course, keep everything ready. Maybe simultaneously, if at all you feel she's bleeding, you can go ahead with the stepwise devascularization also to minimize the blood loss. Now what happened, actually this patient was being taken up for cesarean section because of her severe headache, everything. We just had a suspicion that she may have something else in the in cranium, intracranial region. So she was taken for MRI. So while on the way to MRI, she conversed with all these precautions. So then the MRI was done. Dr. Roshan, this is for you, but I will just inform whatever the findings are. So she was managed with antihypertensives again, and MRI showed this, the vasogenic edema. Okay, so she was landed up into PRES, posterior reversible encephalopathy syndrome. All of you know that it is not preventable. There is no definite treatment, and of course, only thing good for this, disease or findings, you can say that if at all it is purely PRES, then it is self-resolving condition. Over a period, the patient can land up into some neurological deficit, maybe she can land up into blindness, but within a period of 1 week, she usually recovers well. That is what we have to, but you have to make sure that she doesn't have any other intracranial organic pathology, right? So, friends, crisis is integral to human life. Those who timely and appropriately contract it will survive and succeed. That is what Geeta said. And that's the reason we have to be very, very vigilant when we are managing such patients. We have to keep a very high index of suspicion that your patient is going on the track what you are thinking, or maybe there are some variations, and definitely we can, though we cannot prevent hypertensive disorder per se, because there is no definite etiology known even till today, but we can definitely minimize the complications associated. Though I said that we can predict. So from early pregnancy, if you start Aspisol, that is aspirin 75 milligram, and the high dose calcium nowadays recommended is the, according to the latest recommendation, 1.5 to 2 gram of calcium is correct. So this is how I think we can prevent or maybe minimize the incidence of hypertensive disorder, reduce the complications and the morbidity and mortality associated. So friends, I just thank all of you and humbly utilize this opportunity to talk to you and request you for my candidature as FOXY Vice President. Please do bless me, the seniors, and do support me, my dear friends. I request you to vote for me during the elections, which are very close now, from 1st to 10th August. And from West Zone, you have 2 posts. So make sure that I'm your first choice for FOXY Vice President from West Zone. Thank you so much once again.
Thank you, Dr. Sneha.
Thank you.
In between, I have to leave. But otherwise, I have
Mm.
seen you talking. You are really a wonderful, amazing speaker, and really our first choice for the vice president post.
Thank you, my dear. I was just searching for you, and in fact, I wanted to request you for your comments on the topic also, please.
Yeah. You have very well said from starting from the control of hypertension and what are the complications regarding this. We have to see whether the blood pressure is existing pre-pregnancy, and many times it comes to normal because normally there is a fall in blood pressure during the normal pregnancy. So many times there is a confusion because when the patient comes to us, have not taken any pre-pregnancy blood pressure, so there is a lot much of confusion. So patient has to be followed very properly and to be seen that whether this blood pressure increase that happens after the 20 weeks and come back to pre-pregnancy level 12 weeks post delivery. This is very important point. And of course, you have very well said about the drug, about the different features of diagnosing the preeclampsia, features of preeclampsia, not only the urine, as we see nowadays in each and every patient of hypertension, gestational hypertension, we test in our OPDs whether this is +1, +2, very easy method. But along with that, in many cases, the recent data says that if you, along with hypertension, urine protein is not positive, we have to see for the other features, like you have very well discussed about the platelet count, about the liver transaminase level. They are more than 1.1. There is an increase of serum creatinine, and features of cerebral edema like and epigastric pain. This all should be considered. Regarding the BP medicine, you have very well said about the labetalol, that is to be used because this is very more efficient, freely available, and rapidly acting, and the effects of the methyl dopa that comes after 24 hours, and there may be some features of like vertigo, etc. because of that. There's one feature also, in many person there may be proteinuria because of this methyl dopa.
That is there in literature, but this labetalol, it is not there. And in IV cases, if it is high, more than 160, 100, you start labetalol IV, we can go up to the maximum of 220 milligram, not more than this. You very rightly discussed about all the medicines. Nifedipine retard dose, that is to be given, and hydrolazine very less used by us because of it's rapidly acting and drops the blood pressure very soon. So depending on all this, and when to use the magnesium acsulfate, you have very well asked about the Richard regime, and both the regime were very Jospin regime, very well discussed. And again, thank you. Starting with the all these, you have discussed everything very well. The indication of cesarean section and what anesthesia to be used. Again, my congratulations in advance to you and best wishes. You are really super and can be our best choice.
Thank you so much, dear. Thank you so
Hi,
much.
Sneha. Dr.
Yes,
Sneha,
yes. I was
yeah,
inviting you only. Yes, please.
yeah. अभी डॉक्टर आशा वो है क्या अलका सेठी आपकी दूसरी एक्सपर्ट? If she's here, she can talk. No.
नहीं,
So like,
शायद नहीं हुई,
yeah.
पता नहीं क्यों. हाँ.
हाँ नहीं दिख नहीं रही हैं, but I think if she is there, so she should get opportunity to speak. So wonderful panel and very informative. But as we all know, Dr. Sneha, that in the two line, the message is only that preeclampsia, eclampsia, hypertension, it is always remain dilemma for all of us. And as Dr. Malhotra has said in the last, webinar, that obstetricians, the first we have to make a good obstetrician. Only then we have to know that laparoscopic, that IVF and all. And this is really a very good. And what I feel that for last 25 years, I am in the medical college, that I see the things and the patients come from periphery. We have to train all team actually. So most of the time our 30% the doctors, they knows everything, but some doctors, they are not actually aware of the fact. So we all have to train together. We have to update all together so that we can give optimal management to the patient. And even in the patient's awareness is very important that what is this preeclampsia, why they have to come to regularly for the surveillance and all. So thank you very much. Excellent things and best wishes. No doubt about your caliber and no doubt about your eligibility, and definitely you are a truly deserving person. Lots of wishes from bottom of heart. Good luck.
Thank you, my dear. Thank you so much, all of you, Madam Kirti Dubey. Thank you so much for so much of help.
Neha, this was a wonderful session, and I really enjoyed the panel. And I'm so thankful to you that you have really revised all the management of preeclampsia, and it has been. You have updated not only the youngsters, but also I would say the seniors. We have been using all these things, but it was such a nice revision of the subject. I really loved and enjoyed the panel. And all the best for the forthcoming elections. You are in our heart, and you are the best person and the best candidate for the very post for which you are contesting. All the best, Dr. Sneha.
Thank you, madam.
And
Thank
yes,
you so
and congrats to all esteemed panelists. They all have done wonderful.
Do we have all our panelists? At least 1 second, you can put on your video. All our panelists. Can you please put on your video, Garima, Dr. Rakhi, Dr. Deepa, Dr. Tina Sahu, Dr. Jayashree Pathak, and I think Deepa Saxena. So all of them were very, very good, excellent panelists. Can I have your opinion about the subject, and how did you feel that whether we should have such panel discussions or we should have the theoretical recommendations?
No, ma'am, this was good enough, ma'am, because everyone wants to take the practical points we need to take.
Yes.
So it's really very practical day-to-day problem that we face.
Thank you. So I used to always, I always have that mission that, everybody is well educated and qualified. All of you have access to the internet. You will have all the recommendations and guidelines from the book or internet. But what is, the practical aspect of it? I think if you have case-based discussion, that gives you very good take-home messages. That is what I feel, and that's the very reason we decide to moderate in this way. So I'm very thankful to all of you. I really enjoyed moderating your panel discussion with all of you. Thank you so much, dear all. And
Thank you so much, ma'am.
thank you so much. I seek your wholehearted support. And of course, if you feel I deserve, please do vote and support me from your society. Thank you so much. Thank you. Thank you so much. Bye-bye. Good night.
Good night.
Good night. Good night. Bye-bye. Do we have Nutan? Good night, Dr. Deepa, Dr. Rakhi, and of course, yes, Nutan.
Yes, yes.
Yeah.
Thank you, everyone. And thank you, Sneha ma'am. I think everyone is enjoying your academically so much of efforts in the entire academic work. Thank you, each and every president and secretary, for joining. And it's always a pleasure connecting with everyone. Thank you.
Thank you so much, all of you. Thank you.
Thanks.
Good night. Bye-bye.
Good night.
Good night, ma'am. Good night.
Thank you, Pure, for all your efforts. Thank you so much.